He launched this product and he launched this product on how to collaborate, innovate and even conduct a conference in that app. Innovations designed not just for metros in the hands of frontline clinicians. We had a panel on AI, artificial intelligence, data and digital intelligence, and enter the conversation around hospital management, providing that intelligent hospital is not a concept of the future, it is built right now. So no more the future of healthcare ever changing, and we have to adapt it. Yesterday we had a discussion on AI, and there is a debate that will AI replace the doctor. We had a fruitful discussion. Some doctors told it is necessary to have knowledge on AI. Even we can, the change in the field of medicine entirely within the range of AI. But some other panelists said, as a doctor, you need a human touch. So there is a lot of debate and fruitful panel discussions on AI. And of course, our startup showcase reminds us the boldest solution to healthcare's biggest problems are often born in smallest rooms by the most determined minds. It's true, it is not the place where you belong, it is the idea which is how it is to be executed. And I would like to thank all the stall managements and for exhibiting your product here in MEDIEDGE Edition 1. So, with the recap of day 1, so what does day 2 look like? So I would like to invite Dr. CARESUMMIT to come over and tell how their day 2 will look, and the panels has to be discussed. Thank you once again. Thank you my team as well as all the delegates, those who are attending. As today is Sunday, there will be a lot of commitments and to the doctors. So we will be expecting more doctors coming, and we are getting a lot of calls. Thank you. Over to the issue.
So I will speak up of day 1 today. So it is completely about building momentum. So we opened with the vision, we talked about the critical care without boundaries, about elevating the I skills.
Hello. Company. Bukan.
the recap of day one. It is about building momentum. We opened with a vision, we talked about critical care without boundaries, elevating ICU excellence in emerging India. And we also asked ourselves, why should a patient in Tier 2 city receive anything less than world-class intensive care? So we witnessed transformational conversations about healing, leading, turning doctors into healthcare visionaries. So we had 2 product launches also, and we celebrated precision medicine's role in defining cancer care. We saw AI, data and digital intelligence. So we ended with AI in healthcare. Around hospital management, proving that the intelligent hospital is not a concept of the future, it is being built right now. And of course, our startup showcases, they reminded the boldest solutions. So today, what does day 2 look like? So if day 1 was about discovery and disruption, day 2 is about depth and direction. So if day 1 set the fire, day 2 fans the flames. So today we go deeper, we go broader and we go bolder. So here's a glimpse of what is about our day 2. So we'll explore the next frontier in medical imaging and also regarding interventional cardiology. So we will begin mainly with medical imaging initially, the next frontier in medical imaging technology, which is little challenging, what the human eye can see inside the human body. Next we will discuss regarding medical device manufacturing powerhouse, then about interventional cardiology, surgical robotics, rehabilitation and recovery, and we'll end with aesthetics and dermatology. So we have one more product launch today. Along with that, we will discuss regarding few of the startups in the startup showcase. So, and at the end of the day, we have a valedictory ceremony and healthcare awards. So, in 5 minutes, we'll begin with our first session. That is the next frontier in medical imaging. Dr. Saujan will lead it. We'll introduce him in some time. Thank you. good morning everyone. So today we will start our sessions regarding our panel discussion. So our first panel discussion for today is Seeing Beyond, the next frontier in medical imaging. So this panel will be moderated by Dr. Saujan Reddy, MD Radiology, Fellowship in Neuro and Vascular Interventional Radiology, currently working as Associate Consultant in Interventional Radiology in Yashoda Hospital, Secunderabad. So he will be introducing the panelists and let's start our first panel for today. Thank you.
Good morning everyone. It gives me immense pleasure to welcome you all to MEDIEDGEHEALTH Summit Day 2. I would like to welcome our panelists for today's topic, Seeing Beyond, the next frontier in medical imaging. Here we have with us Dr. Chinna Nayak Banod, MBBS Usmania Medical College, DNB Nuclear Medicine, Bar, Mumbai, founder and director of IRIS PET CT Center, Karimnagar. Sir is a former consultant at Vijaya Diagnostics, KIMS, Omega and Star Hospitals, Hyderabad, with over 10 years of experience in nuclear medicine. Currently, Sir is full-time nuclear medicine consultant at IRIS PET CT Center, Karimnagar, providing comprehensive nuclear medicine services, including PET CT, gamma scans, and radionuclide therapy. Welcome, sir. Next up we have Dr. Manisha Joshinath. She has completed her MBBS, DMRD, DMD Radiodiagnosis, DM Neuroradiology from PGI Chennai. I am a senior consultant interventional and neuroradiologist at Yashoda Hospital, Secunderabad. With over 10 years of experience and special interest in neuro and peripheral vascular interventions and non-vascular image guided interventions. We welcome you now. We have Dr. Major MD Kajam Mohinuddin sir. Sir has completed MBBS, MD Radio Diagnosis, Fellow in Vascular and Interventional Radiology. Sir is ex-Major, Indian Army Medical Corps. Sir is currently a consultant in Diagnostic and Interventional Radiology. Sir has also got fellowships in NSK MRI, fellowships in pancreatic imaging. Welcome, sir. So the topic for today is Seeing Beyond, the next frontier in medical imaging. The medical imaging today is no longer limited to simply identifying diseases. It is increasingly helping us predict the outcomes, personalize the treatments, guide therapies, and even intervene in real time. From artificial intelligence and advanced MRI techniques, molecular imaging, PET CT, we are witnessing one of the most transformative eras in the healthcare. Today we have an excellent multidisciplinary panel representing interventional radiology, diagnostic radiology, nuclear medicine. Hopefully looking forward to an engaging discussion in the future of imaging sector. Let's begin by looking at the bigger picture. Let me get the first question. What do you believe will be the single biggest transformation in the medical imaging over the next decade? Each of you can take some time, 30 minutes to 30 seconds to 1 minute, and give your perspectives on that.
మీడియాస్ కొట్టరా అంటున్నా వద్దు అట్లా నిల్చోవాలండి.
In those cases, PET helps in identifying the therapeutic focus and therefore treatment of the patient. So one point is that PET terminal.
last door open.
So one point is pattern. So and the next point would be, I would say, PAPI image. PAPI would be available, like particularly very helpful for me because I am having PET CT in Karimnagar. So to do a PET CT scan, I will get medicine from Hyderabad. We have cyclotrons in Apollo and Nado, two sites. Substance 50 for AP and connection.
Only
So
photograph.
every day my vehicle goes down, travels and get medicine from there. So if the PAPI comes in, it is a similar research like FPG only. Where we can do, if we keep a generator, in-house generator, just like gallium, lotus scans, gallium PSMS scans we do. So similarly, gallium enabled PAPI scans, which can replace FPG. So it is similarly as effective as FPG. So from nuclear medicine point of view, after 10 years we may see more of PET MRIs growing and PAPI will be replacing this PG. And therapies will be more aggressive. Like when I started learning nuclear medicine, we used to have only nutrition, PRRT, neuroendocrinology. But now we have already having seen nutrition, PSMA therapy in palliative care, process. So therapists may take over. More of therapists will come. In Western countries, they have separate particular research on this therapies. In India, there is not that much, but certain issues like AIDS and RSV, they are doing some clinical trials kind of therapies because they do it for free. So they are attached to Tata and even AIDS have good volume work. So they are doing some more of traditions, but yet to see progression in that. This is from nuclear medicine perspective.
What do you think would be the next biggest transformation in the world?
Yeah, from IR perspective, it's no more like doctor behind the screen. It's beside the patient now. So in the field of intervention radiology, we have very invasive procedures like drainage, then vascular procedures, angioplasty, then coil, tumor embolization, everything. It is like more education should be there, and IR should run a separate field on that, so that it could reach everyone and every patient.
So I think we can focus on three important aspects when we discuss medication. One is of course to get a more higher normal technology, and we are moving towards a direction where the AI has been coming and technically more and more advancements have been coming. I will come back to that point later. But more important than that and more time, something which is important for this particular time in this particular place is that availability of the currently available modalities in every corner of the world or every corner of India, whatever we want to discuss. So as I mentioned that PET-MRI has been there in the Hyderabad or one or two places, but it need to reach to other places where it can reach to have more patients, and it can cater to the all population, not only to a particular group of the population. That is another important frontier which we look forward to have in the imaging or IR both. Second thing, the utilization of currently available resources. Because being a radiologist or being an intervention radiologist, I genuinely think that we are underutilizing the imaging services, or we are underutilizing the function of the imaging. Because whatever we are doing with the imaging or the interventions radiology as of now, can do much more and much better with the same resources and the same number of people as well, with more understanding and with more education, and giving the more personalized care and giving the more precise care to the patient. If we think about the patient's problem, that what the problem patient has, if we think about the available modalities, many times we will be able to get a new solutions for that compared to what we have done in the books. So these two are the most important things I think in the, which are can be available with the currently available resources and which can be available with the currently available technique. Now coming to the new technique, of course, because imaging has reached deep and deep into the tissue and deep into the body. We all might have seen some reels or some YouTube videos where we will be seeing the digital image of the whole body, and then we can see the digital image changing and transforming, going deep into deep and showing the deeper tissue from the skin to the bones to the brain to the soft tissue as well. So that's definitely a future. May not be currently maybe just a sci-fi kind of thing, or maybe just something that is development at some place, but definitely it is a future. And technically, if you ask me, I am of course looking forward to a whole body multi-parameter imaging. Not only the imaging displays the resolution of the particular soft tissue or particular bone. We have a whole body CT, we have a whole body MRI as of now, but whole body multi-parameter multi-contrast study where we will see the tissue in the contrast which is seen in ultrasound, the contrast which is seen in the CT, the contrast which is seen in the MRI, and of course the physiological as well as to the anatomical details as well. So definitely the future is right, and I think utilizing the current resources is the most important thing which are available in our scenario, which are available in our city as well. Currently we have a lot of ultrasound machines and a lot of CT and a lot of MRI machines, and I think much better can be done with those same machines and with the same number of people as well. So I think we should try to do the maximum utilization of those. Along with that, of course, technique will be coming and we will have a better and better technique in the future.
In the next 2 years, multi-parametric imaging, like you said, is definitely a new idea. What they have quite sitting all together using scanning equipment. And AI will also be the next biggest thing. When coming to AI, definitely artificial intelligence is probably the biggest disruptor in the healthcare today. Do you see AI as a threat, a tool, or a transformational partner for a radiologist? Please.
So AI is here. It's going to stay with us. It's not going anywhere. And it's going to incorporate more and more into our lives in the future. So we can't get away with this. Of course, part of me is scared of it. So when I heard about it first time and when I saw it first time working, of course it gave me a thrill down my spine that okay, what is it going to do? Will it get me out of the work? Will it get the people out of the work? Will it include the future generation? Because future generation will start using their own mind and the AI will be the one who will be dealing with this. So, but yeah, all those facts are something that are non-modifiable. We can't do anything. The technique has been correct. We should keep coming. But what we have to focus on is what best use of it we can make of it. Because some things which are in our hands is like how we use it and how we educate our next generation to use it. So we have to look forward to not to allow our natural intelligence to go down just because AI has come up. We have to think of that how we use AI to increase the utility of our natural intelligence. So that's the part we have to focus on, whether it is the medical or non-medical part. Coming to the radiological part, of course, we see many of the reports being generated by the AI now. In the future, of course, there will be more and more reports by the AI. But the role of the radiologist is not going to go away. But I think the radiologists, what they should do is that they should come out of a textbook. Now, it's the right time to come out of the textbook. It's the high time to come out of the textbook and then do the actual clinical work of the patient. Because nowadays, I think if you ask any physician or ask any surgeon, I think that they can echo the thought that almost 50% or more than 50% of the decision making in the treatment is being done by the radiological tools. So if the radiologists start applying their mind clinically as well along with the radiology, and if they take the help of the AI, they can be much more efficient and they can provide a much more precise care to the patient. So I think we should focus on the more brighter side. Of course, there is some dull side which we have to deal with, but if we focus on the brighter side, we can make the best use of it. So.
Yes, sir.
we should learn how to live along with AI. We should not feel it as a threat. We should take advantage of it. We should we should use it properly. Even nowadays, one robotic arm is there in nuclear medicine, in AI hospital. They are doing pet-aid biopsy in PGH and AAG Hyderabad. They are doing pet-aid biopsies with a robotic arm. So where they are using a robot and they are precisely doing pet, and if we keep a robot there, we can minimize the exposure of customers. It does along with the study. When the pet CT is done, simultaneously we can do a pet-aid biopsy from there itself. So there we plan from, and so we do that, just we guide it to where to how much depth it has to go and how much tissue it will take. We just do it from a system only. So that is one. But it can't replace, AI can't replace a doctor, that is for sure. So what I feel is we should use it to give a good result from diagnostic per se or any therapy as well. So I don't feel it as a threat. I don't feel it as an advantage for better diagnosis or better treatment of the patient.
Sir, so from interventional radiology perspective of view, do you think procedural specialties are relatively protected from AI disruption? Do you think they are safe, sir?
Absolutely. AI can only navigate, show the vessel mapping, everything, but it can't replace the handful skills. So definitely we can take advantage of the AI in procedural skills, mapping, then device selection, everything can be done with the AI. We can incorporate into the better patient outcome and the procedural outcome. But it definitely it can't replace the handful skills.
Yes, sir, definitely. So perhaps the question is not AI versus radiologists, but AI alongside radiologists. Let's also talk about some diagnostic radiology. What recent advancements in CT and MRI are genuinely changing the patient outcomes today?
Recently in the city, photon cities has been developed and early acquisition, low dose reduction cities has been introduced. So all these helpful to the patient. And in the MRI, advanced images like ASL imaging, DWI, which are useful in the stroke to see the penumbra and calculate the intervention. And recently the major advancement is stroke is not a clot decision now. It's a tissue decision now. So based on these advanced imaging sequences, we can plan even the thrombectomy beyond 24 hours. So previously there is a dictate after 6 hours we should not go for thrombectomy. It's no more like that now. It's a tissue diagnosis now. If the penumbra is more than the infarcted core, so we can plan thrombectomy in such cases. So these are the advances in the CTs and MRIs recently.
Yes, as sir has mentioned already, we have a photon counting city coming, and I think one or two centers in India has already installed it, and the images are beautiful, fabulous, and so impressive that of course we are looking forward to it with open hands. And the MRI and ultrasound, I think there are some things like multi-area ultrasound probes kind of things are in the development, where we can be able to get, rather than using a single probe we are using right now, probably in the coming future we are going to have some probes which are like MRI coil or something like which are kind of blanket kind of thing on the patient, or something which is covering the part of the body in the bigger area compared to what's the current probe is, and can take the image directly from there with less hindrance from the air and less hindrance from the ceramic sensor. So then we will be able to make a 3D image of ultrasound in the lesser image and taking the large amount of tissue and in fact showing the physiology of the bowel movement and some other things as well. So those are in the development as per my knowledge, but yeah, I think it's too long, it will take too long for it to come. From the state stroke perspective, Because stroke imaging earlier used to take like almost half an hour to 45 minutes. Now we are close to 5 minutes to have a basic stroke imaging now. So which is very important because stroke patients are usually hesitant, they are usually not cooperative, they are usually something which may be unstable as well, they may escape out tables, they may need the intubation very soon. So faster imaging is very important in the stroke patients as well as other neurologically bad patients as well, where they can have a lesser time. And portable MRI, portable CT scan as well as the intra-op MRI or intra-op CT scan has been very useful nowadays, which gives us an in-depth idea during the procedure itself or in the ICU patients in a faster way without mobilizing the patients. So, of course, we have a lot of technical advancement. If we start getting technical advancement, I think it will be half an hour, 45 minutes to just discuss those, but I will close with this.
Definitely not portable CTs, portable MRIs, just like portable X-rays in the future, but that specifically see that it's like advancing in the imaging happening faster than being adopted clinically. Like we have seen in Karimnagar, I still know some centers running for 16 slicing. We're talking about functional MRIs or perfusion mappings. So how can we bridge the gap? Are we advancing very fast and we can adapt?
So, in adaptation, the main role comes of, I think, finances as well as education of the people who are using it or the technical knowledge of the people who are using it. So, we are advancing very fast, but yes, to get the reach of all these techniques into smaller and smaller areas, that will definitely take time because there are a lot of practical hurdles to that. But now we have solutions available. Earlier there were the problems, lot of problems, but we didn't have a solutions for that. Now we have solutions, somewhere we can see a silver line, and probably it will reach to us very soon.
I feel Karimnagar has everything now, so there is no need to fill the gap between the Hyderabad and Karimnagar. So whatever available in Hyderabad, that is available in Karimnagar now. I feel we are almost equivalent to Hyderabad in technology per se or whatever imaging per se. So we are just in parallel to Hyderabad now. That's what I feel.
Definitely, sir. So coming to you, I have a special question for you. PET-CT and molecular imaging are rapidly transforming oncology and precision medicine. How do you see nuclear medicine shaping the future of healthcare, especially in diabetic cities like us?
Yes, good question. But the main intention of me coming from Hyderabad to Kerala and starting a PET-CT, the main reason is this only because Kerala have two full-fledged oncology centers without a PET-CT. So they do good radiotherapy missions, they have good radiotherapy missions, and they do have good medical oncologists, they do have good surgical oncologists with advanced theaters, but they don't have nuclear medicine in Kerala. So the patient travel from Kerala to Hyderabad to get a only PET scan and Hyderabad and they come back for the further treatment. So I feel that gap between the oncology treatment for a patient. Even most of the patient affordability is an issue, and the second is viability of the my center point of view, viability, because even Chelmeda have a big oncology setup. They would have started PET-CT along with the oncology. And even Omega have a good oncology setup, but they didn't have PET-CT. So maybe because of the viability part. So the cost of the infrastructure is very huge. To make it viable, they need some minimum number of patients. So I took the risk and I started PET-CT in Kerala. So I feel now we have complete treatment, full oncology treatment available at Kerala. So that is the reason I am telling Kerala is more or less equal to Hyderabad in every aspect of the medical treatment per se. And we not only have PET and gamma camera, we also in a way to get a radionuclide therapies. So radionuclide therapies in like CA patients, we need a isolation ward. So we are trying to get it in Karnataka as well. And we have permission for nutrition therapies, neuroendocrine for LEDs, for as palliative treatment, they used to give it a nutrition therapy. Even that is making it available in Karnataka. And even for palliative cases, severe prostate cases, there is a nutrition PSM therapies. So I'm trying to get both those therapies available in Karnataka. So the permissions are in process, but they will come soon. So for oncology perspective, Karnataka is more or less in same track with Hyderabad is what I feel. In future perspective, they may need help to get this FAPI, because even FAPI they do really use in Hyderabad, very few patients, because they have good availability of FTG, so they are not behind it. But for me, FAPI is very useful, because if in emergency I can do PET-CT any time. So future may come like PET-CT any time, kind of thing. Just like we do CTs any time. So if we have a FAPI, we can look at any emergencies. But since it is not an emergency, it's an elective thing only. So it doesn't get that much popularity, but it will come first around 5 to 10 years. And I think I have covered almost nuclear medicine. I'm trying to cover it and get it in Canada.
I really agree with you, sir. Coming to interventional part of view, what are the biggest barriers preventing wider adoption of interventional radiology in India? So you're practicing in Karimnagar, you could probably tell us more about it. What are the biggest barriers in which?
The main concern is it is a newly developed branch, interventional radiology. So most of the physicians themselves are not aware of it. So the first thing what we need to do, we need to spread the educate every doctor about it. And the second is multidisciplinary approach should be there. So now being a prospective of radiologist, doctor behind the screen, it should be patient. It should be in such a way that doctor is beside the patient now. So we should involve in tumor board discussion, vascular board discussion, ICU, and everything we should involve. And before it was a prospective, like surgeon needed imaging before surgery. So now it's like imaging itself is a surgery now. So intervention has to be reached to everyone. We need to educate everyone. Yes, more education, and IR1 clinic should be there. There is a separate IR clinic has to be developed. We need to focus on that.
Ma'am, you worked in many states of India. How do you think that what is the barriers in reaching multiple places?
So, barrier has been that started very late. Because intervention radiology is not something new. It existed almost more than 20 years back as well. And the advancement has been constant in the intervention radiology. The uses has been vast since starting itself. It's not that the vastness started now only. But because of remaining in hidden areas and remaining in the more confined areas, we ourselves got to know about it very late. And of course, a lot of our colleagues, public are get to know it. So the biggest factor is that we started very late. That's the time barrier which we had from the starting. But now, of course, it's not something non-modifiable. We can't undo it. But now it is the time that we can reach out to more and more people, and the intervention particularly can reach out to more and more public as well as more and more physician community as well. When I talk to my friends, close friends even who are the doctors who are from the same medical team, and we have a discussion that okay, who is doing what. So usually it is a part of curiosity which we see that okay, what you are doing as a intervention did they exist actually? Was it there earlier? So was it there even 15-20 years back when we were starting our medical journey, maybe 25 years back or so. So when we dig down, we found it exists, but we didn't know about it. And now we have kind of social media, and we have we are getting to know what is happening globally and anywhere, I think we can have a more faster population in the public's mind, as well as we can have a more faster knowledge in our own community as well, that what can be done with these things. Because there are many patients who are lying at home without getting the solutions, which can be solved with some techniques which do exist right now itself. So we need to think in the problem-solving mentality. If we have a problem-solving mentality, probably we will issue solutions, and those solutions do exist. So of course we need to teach ourselves, we need to educate ourselves as well as our own community, and then see that whether the changes can be forward.
Actually, I would like to add one point in this. Dr. Moinuddin sir is there in Karimnagar. He handles every intervention in Karimnagar. So sir has good handling. Just we used to do pet care batches at our center with the help of sir. Even I didn't get notice that the procedure हो गया. मतलब सर आते हैं ऐसे करके निकल जाते हैं. मतलब इतना fast है, इतना accurate है, and is very good hands. So we have one gem of product in Karimnagar to do any intervention. So he served us every intervention, not only specific to any single made batches. Served us every intervention. So I feel we should appreciate Moinuddin sir for that. He would give his services in Karimnagar. So just wanted to add that point.
So bringing it to diagnosis as the main agenda of MEDIEDGEHEALTH Summit. Sir has already started it before us. Yes. One more question regarding AI. This could be a little controversial. Will future radiologists need AI literacy, even coding classes or coding knowledge?
I think the answer is yes. So maybe coding or maybe some other technical part, but yes, we need to be more tech savvy now. And now I think even from the class 4 or 5, I see a lot of advertisement on the social media that they encourage children to start coding, and they encourage children to start working in the technical field. So technique is a part and parcel of our life now, and of course the children who are coming to it and who are in the future going to be the part of future generation, they will need to be more tech savvy. They will need to understand more part of what is the analysis, what is the AI, what and how, where it comes from. So they will need to have a more knowledge about it. But that will be part of their education from the primary school onwards, I think. So that will not be something very specific. It is not, AI is not only into medicine, but this is everything. So whoever is a child now, when they grow up, the AI will be incorporated. So it is already incorporated into their in their curriculum or in their life from the primary part itself. If you see the child now, the 6-year child, the 6-month child, who may not be able to speak, but they can do some things on the code, which we can never imagine. So that is a part of their genome now, I guess.
So as the imaging becomes increasingly AI-driven and technology-dependent, how do we preserve the clinical judgment and the human aspect of the medicine?
At the end of the day, the clinical symptoms, clinical history plays a big role in any report. If we strictly follow this protocol that we should take history proper before giving any report, to see the proper file, and if needed, we used to speak to patient and then what the further results. So definitely we can't, even though we are in diagnostic era where we do scan for to know everything, but clinical history it has its own role. We should follow the basics kind of thing. Just like any cricket who follows the basics, we should also follow basics. It's of taking history where we learned in our UG department what is the importance of taking history. So I feel we should stick to that. For every patient, clear that history is mandatory only. So it changes, even sometimes we may not get diagnosis on any CTR, MRI, or PET. With adding history to that, we will make a better diagnosis and we will help in the treatment of the patient.
Yes, sir. Definitely, I would like to emphasize one of your points.
I would like to add one example in this. Recently, we did a bone scan of the patient. patient, young patient, 35 years male patient is having severe pain, severe knee joint pain, right knee joint. And I without history, I like saw the scan before seeing the history of the patient. So after seeing the scan, again I called the patient and I asked. So patient, imaging wise, the patient is having a severely FDG with light focus in proximal kind of thing, and it is actually aggravated in night time. He didn't tell that. So I suspected that because it's a need a sinus C, sclerotic focus with the lytic focus with sclerotic, lytic lesion is sclerotic focus in this. So night we see clearly seen. So I thought it's a osteoarthritis kind of thing. So I retrospectively called the patient and asked him. So he gave a clear history of getting out of bed in midnight because of that pain. He used to get severe pain in only night times, and sometimes he get out of the bed with the severe pain. So that recently I treated our center only. So it is osteoarthritis. So here the history plays a important role in this.
Definitely, sir. Retrospective history and history taking. AI will still take a lot of time to do that. Especially, let me just quote an example. The old lady probably thinks she's taking her hypertensive medicine every day. Would come to us, tell her I'm taking medicine every day after my breakfast. But AI wouldn't probably just check which medicine she's taking. She's from some rural India, which she wouldn't be able to answer on an app, telling that which medicine she's taking. Definitely, we might have to ask them to show the slip that they're taking. Probably it will end up being a pantoprazole. So that definitely, that human aspect of the medicine is still going to be there. Yes, sir. In one sentence, what does the next frontier in medical imaging mean to you? Each one of you just to give you one thing before we close this session.
So, as we discussed about this point, same idea that what's the next frontier. For me, it is a three-level approach. One is the technical advancement, second is the utility of the appropriate utilization of currently available resources, and appropriate reach of the currently available resources. So I think if I want one of them, will be appropriate utilization of the currently available resources.
I think it is to create awareness about whatever we have and is where we were. So creating awareness is more important from my point of view. Even we get good technology, even we get use AI, whatever the latest update technology. So without creating the awareness of that, whatever the availability is you are creating, that is of no use. So I feel more of using social media platforms and using artificial intelligence to create all the social media stuff. So doctors can use AI in this as well, not only in getting good advanced technology to diagnosis. We can use AI in the marketing, in creating publicity and all. So what I feel, add AI in your practice, but it should be within the limits. We should not overtake it, work parallelly. So what I feel is creating awareness is more important than creating facility. So in future, we may see advanced machines, robotic machines, but still, if you get that machine and without creating awareness, it's of no use. So creating awareness is what I add. Even in oncology as well, what I feel is awareness in oncology screening. Screening will play an important role in coming days, because when most of the metropolitan cities, screening is done aggressively and they used to diagnose in early stages. But in what I felt is after seeing 1 year of experience in Karimnagar, they come very late now. Like after getting they come to us with a background. So when we do MRI, there will be a light lesion in the spine. So then we retrospectively they come for PET CT. So there we see a lesion in lung. That is a stage 1 lung cancer. So maybe screening, adding screening to like cytocity scan, reverses. In Karimnagar, screening will play a good role. in future. But that we need to create awareness of screening.
It's definitely AI because it reduces the workload on the radiologist and precise clinical judgment cannot be made by the AI, but definitely it's an AI. And moreover, the radiologists who use AI will replace the radiologists who don't use AI.
So we are on the stage here, Mediate. So I would like to roll the red carpet for you to each one of you to tell us the great things that you've been doing at each one of your institute. I work.
Which we did not have available earlier. Some of the things that did not have treatment at all, some of them had very difficult treatment, some of them had treatment which are like very cumbersome or very high risk. Nowadays, from head to toe for any part of the body, the minimally invasive treatments are available, starting from the stroke where we can do mechanical thrombectomy, angioplasty, stenting, to open the block vessel, to take out the clot actually, which is like a miraculous thing, which could never imagine earlier. Then for the aneurysms in the brain which can rupture, which can cause a major bleeding, earlier used to be only treatment was available. That too was possible only for a certain variety of the aneurysms. There were many kinds of aneurysms which did not have any treatment available. Either the treatment was too difficult or was not possible. So for those one nowadays we have coiling, fluorometer placement, intracellular devices, sort of treatments which are available nowadays, which can save the patient life as well as the patient's morbidity as well. And it's, if you go down, we have the treatment available even for the thyroid nodules, which can be treated with thyroid nodule, large nodule, medullary water, which can be treated in a very invasive way by the aneurysm ablation, for the bronchial artery ablation, for the pneumothorax, for the treatments which are there for the vascular diseases like the varicose veins, for peripheral vascular disease, the single regeneration, easy regeneration, and most of them are long-term regeneration as well, where the surgical options are not available or even more difficult to be done basically. And for the treatments like prostate ablation or the uterine ablation, which help in getting out of the morbidity of the person if they go through day to day. The females who have a fibroid, big fibroid, symptomatic fibroid, they keep going through it with each menstrual cycle with each day, and they have a lot of bleeding, they have a lot of pain, and they keep enduring this because they think there is no good solution for this other than getting a hysterectomy, which is again a very difficult reason for endometrium. And for the prostate, I will tell you a small story that I had one patient. Prostate embolization is something which has been there for a long time, and it does help the patient a lot who has a prostatic symptoms. But for most of the people, they don't realize they have prostatic symptom, or they don't accept it in front of the family, or they don't accept it with the fear of the surgery and all. So I had one particular patient who had come with a stroke. He was not able to walk. He had a complete paralysis in one side. He came in time luckily, we did treat him, he required a mechanical thrombectomy, he required a stenting for the brain. After the stenting, in a couple of days, he started walking back. But when we found out that he, with all these antiplatelets and all, we saw that he has a Foley's catheter in situ, and he was having prematurity. When we noticed the prematurity, we asked him whether he had a symptom of prostate. He used to see us and thought, no, we had very minimal symptom, very little pain, very little frequency of urination and all. I don't have any symptom. He was not accepting any symptom actually. He was saying, no. Then we asked about history of prematurity, and he says, yeah, yes, slight prematurity, I had once or twice. But it's not completely, there is no problem at all. So these patients, particularly who are on antiplatelets, anticoagulation, they are high. For them who are the recent stroke or recent IVI, it's very difficult to stop the antiplatelets or anticoagulation to do a TURP or surgery. And these patients are going to this hematuria, they can have a decreased hemoglobin levels, they can have repeated infections. For this particular patient, we offered him that time that for your ideal treatment is to go for the prostatic artery embolization to get rid of your prostatic symptom and get rid of your bleeding as well. He was refusing to accept the symptoms at all because I have seen many males like that who are quite accustomed to those symptoms. They will not accept, they will just accept that okay, it is a part of aging, it is a part of my senile age, and it is not a very serious symptom which needs any treatment. And he was one of those kind of person. So discussed with the family also was not agree for the procedure. At that time he was recently underwent a stroke procedure. But then he kept on having a hematuria. They came back after 4 weeks or 6 weeks. Then we offered them the treatment again. They were ready for the treatment. He underwent the treatment. Till then, from the time of stroke, he was on Foley's catheter. He was never out of Foley. Although he was able to walk, after the complete hemiplegia, he had recovered completely. He was completely aphasic. He recovered completely from being a bedridden person who did not have any power on the right side. Was completely aphasic. He was walking. He was talking completely. But only problem he was having hematuria, which he was now ready to get treated. Now we treated him with the prostatic anti-ablation, and the person who was saying I don't have symptom earlier, after the prostatic anti-ablation he came to us for the further follow-up. After 2 to 4 weeks we used the Foley's catheter. He was voiding by himself, and then every time he comes to my OPD he thanks me a lot for the prostatic anti-ablation, for getting rid of the prostatic symptom. He never thanked me that I made him walking from the hemiplegic condition. He never thanked us for us. That is how important the prostatic symptoms were there for him. And he came to my OPD before I left the place. He came to my OPD for 4 or 5 times, and you can't imagine the gratitude the person had. He will come jumping, he will come smiling, and he will keep saying, "Ma'am, thank you for this, my symptoms of the prostate." So that is what the condition is, that these are chronic conditions which can be treated with a much better ways, but not having the knowledge and not knowing that what it can do is something which is a big barrier to reaching those solutions.
Definitely, ma'am. I was also amazed by the level of depth of treatment options here. We usually have the clots retrieved from mechanical thrombectomy. We send it for histopath examination. So we know where the clot has come from and how do we treat that patient in future strokes or future complications. That's great, ma'am.
So how I would convey this, actually we have complete set of PET CT, PET CT, gamma camera and radiographic therapy set Karimnagar. Mainly I'm just focusing to get a full-fledged nuclear medicine in Karimnagar. As I said, to avoid patient traveling to Hyderabad to get a scan and get a therapy done. So we have PET CTs, we have calendar scans as well, calendar PSMA scans as well, and even we are doing EXPO scans, and even we are having a fully functional gamma camera now for particularly any thyroid scans, VT radiogram, DMS scans, even myocardial perfusion imaging to look for indelible ischemia, and even myocardial viability scans there, and complete nuclear medicine. I'm trying to get complete nuclear medicine to Karimnagar. So yes, maybe as I said, even though AI comes, but it will help me to get more scans done. And even as I said, after 10 years, what is your perspective? So some new technology might come, but it won't replace you. It will replace doctor. So what I feel is, you be yourself, you just keep on doing your work, and no one will replace.
For cath lab procedures, so I am using the Adarsh and Sunrise cath lab I am doing. So recently I have done lingual artery embolization was done, and IVC filter placement was done at Karimnagar. So for vascular procedures, as sir said, we are using PET-guided procedure. PET-guided, they are doing precise location targeting they are doing. So I'm thankful to the person for seeing that.
No, we are doing interventions as well as PET-guided biopsies using taking help from audience. So we have started that recently, but we have done good number of cases.
The outcome of the results is also good because the precise location we are targeting. So outcome is also good. And morning hours, with Chalmeda, we are doing one vascular procedure over there. The drains as well as the biopsies over there. So this is the routine.
Very good, sir. So today's discussion reminds us that imaging is no longer just about seeing anatomy. It's about understanding biology, predicting diseases, guided therapies, and transforming patient care. The future of medical imaging is not just clear images, but smarter, faster, and more personalized healthcare. Thank you to all our esteemed panelists and to the audience for being part of the exciting discussion. I would like to welcome our organizing teams. I want Dr. Rajkumar sir to just present Dr. Srinath sir.
Signal. Low frequency.
I welcome Dr. Priya ma'am, President Dr. Manisha Joshi ma'am with us. On the conversation. I'd like to welcome Dr. Sriteja ma'am to the token of appreciation to Dr. Moinadil sir.
Group photo. ఫేస్లో మీద టచ్ అయితే అయిపోతుంది ఈ అందరికీ అవసరం లేదు రికార్డ్ అవసరం లేదు ఇంట్రడ్యూస్ మై సార్ ఇట్లాంటి క్యాపిటల్ ఏమైందా
That was a wonderful session. Now we'll start with the next panel discussion. Seeing beyond not just as a concept, but as a commitment to every patient who walks through a diagnostic center door. The next frontier in medical imaging, that was done excellently, a wonderful session. Coming to the next panel discussion. From innovation to industry, the rise of medical device manufacturing in India. India is the world's pharmacy, but can India also become the world's medical device hub? With the right policy and environment, investment, the answer is a resounding yes. Our next speaker will show us the roadmap from innovation to industry in the world of medical devices. Now to introduce the speakers of next panel discussion. May I request Dr. Saroja Garu onto the stage. Dr. Saroja started her 12 years of experience in physical therapy, healthcare therapies, emergency healthcare innovative ecosystem with strong interest in rehab technologies, digital health, evolving medtech landscape. Dr. Saroja will be our moderator for this panel discussion. Welcome, Dr. Saroja. Now we welcome Dr. Sai Vivek Garu, General Physician, Managing Consultant at the rate of at Praja Life Care Hospital, Sirpur, CARESUMMIT. He also served as General Secretary of IMA for 2 years and is actively involved in advanced quality healthcare and diabetes care. Welcome, Dr. Sai Vivek Garu. Now we welcome Dr. Anvesh Garu, CEO 8MD of Nirvesh Enterprises. He is a visionary neurosurgeon, researcher, entrepreneur, and alums of University of Hamburg and other international universities. He is the author of a book on neuroscience and has many publications. He has a patent on a neurological device in the segment of neurology and neurosciences. We welcome Dr. Anvesh Garu. Now we welcome Dr. Tejashwini Garu, medical oncologist by profession, founder of Cancer Conscious Clinics, MEDIEDGEHEALTH, Fifth Care Solutions with profound experience of healthcare and having a family business in manufacturing industry, pioneered her entry to Fifth Care Solutions into medtech and medical device manufacturing. Now we hand over the stage to moderator Saroja Garu.
Thank you, Raghu. Welcome all. Let's begin the panel session on medical medtech industry. So, Dr. Tejashwini, as a medical oncologist and being an immense interest in medtech innovations and advancements, what do you think global medtech companies talk about India as a manufacturing destination? The ground reality being supply chain fragmentation, skilled labor gaps, quality compliance costs. Let's say tell us a more complex story. What does it actually take a run a competitive medical device manufacturing operations in India today? What's your take on this?
See, India has a lot of opportunity in medical devices, manufacturing and medtech. But regarding the challenges, there is supply chain management to say, there are a lot of supply chain problems over there because in India, if a medical device has to be manufactured, more than 40 to 60% of the parts which are required to develop a device come from other countries like China and Japan. So it is a make in India, but still we are getting it from other countries. So that is one quite big challenge. Apart from that, there is also a lot of skilled labor problem. So to train a skilled labor post-engineering or post any of the manufacturing courses, which India runs, there is a lot of students who are doing engineering, manufacturing and others, but they are not useful to India. And there is also the big giants in medical devices, like the other countries have big giants, so they will be grabbing all the engineering students. So there is a deficit in the skilled labor too. In the same way, there is a lot of financial problems which occur during the quality and regulations. So quality and regulations is another challenge. So despite all these challenges, medical device are better. That is why most of the medical device manufacturing companies in India, they chose to make it in China or some other countries, get a white labeling done from their own company, rather than making it in India itself. So to solve these problems, so one of them is regarding the skilled labor bonding, like having a bond or agreement for 3 to 5 years for most of the skilled professionals in manufacturing. That is one. And for the supply chain management problems which we have, if we can make more of the companies which manufacture different parts of the device. So that is another solution for one of the challenges. And for the third challenge is quality and regulation by using AI and the latest like software. So using that, we can reduce a lot of manpower requirement for quality and regulation. So in this way, I think if we can go ahead, a lot of medical device issues can be solved.
Thank you, Devi. That's from an entrepreneurial point of view. Now from an hospital owner point of view, Dr. Vivek, how do you evaluate new device safety and how does your hospital use, what criteria does your hospital use when you decide to adopt a new medical device?
Actually, when we try to buy a new device for a hospital, anything that we need to do is the patient safety concerns and also the cost effectiveness and also the local, as the Dr. CARESUMMIT was talking about, made in India, made in India. So we need to do those things. And most of the times, the thing is that in areas like where I practice, which is a tightly town in Telangana, we look into the accessibility. Okay. So the accessibility of the machines and also the skill training and the substance in people before going for new device.
Dr. Anvesh, you have a very interesting intersection between a clinician, researcher and an innovator. So, from your point of view, what was the defining moment that pushed you from the clinical frustration to active device development? And what do you think most doctors identify problems clearly, but what was the defining moment that pushed you towards the clinical frustration and active device development? And what was the sequence learning outside of medicine?
So being a clinician, to be honest, I didn't want to start with mentor. Because as you are aware of normal clinician, we do have a lot of patients incoming, not to be the various cases, and everything. But during my clinical practice in Germany, I found that there is interaction between the clinical part and also research part. That's the core thing where I came up with the idea of bringing a first method is called as point of care diagnostic. As you are aware about the Alexandria, Silicon Valley, how they are get, okay? That's the first method. But it got failed. Okay. Then that's the learning curve for me for the enterprise lab. But now coming to this is the second venture device enterprises. This is core from personal experience. Because my grandmother has suffered from stroke and because of second attack she just had a death. Because being a doctor I could help her because there is a tremendous gap between the outpatient care and also inpatient and again continuous monitoring. That made my journey like, okay, why can't we do something beyond the outpatient care and change my experience from research side and keep on learning towards the sensor side and also this is the steepest learning because clinician cannot learn engineering. Right? That's the steepest learning curve for me. And also like more on the perspective of regulatory side also because as a clinician you only know from the perspective of it works or fails, that's it. But from the regulatory perspective and also from sensor side and engineering side, there is a quick learning from my side because of the research background that made me more enthusiasm to put up this particular device called Synapse. So what exactly we are doing is called IoT based brain health monitoring, which is a complete replaceable of CT scan and MRI. They can directly port and they can directly take the emergency care and also understand the brain mapping before intervention. So that minimizing the doctor intervention and also the hours of delay will be minimized. Because it takes almost like 90 minutes, 45, everything, right? So it takes almost 10 minutes to get the real-time data. You can just go to it and you can do the operation circuit. And our device using the AI, we just predicate the second reaction. It's not the first reaction, but second reaction. Because there is a time period window of 90 days. It is really crucial for the stroke survivors to understand the second reaction, right? That we made in a predicate device like that. And that made us more into this field. So being a clinician and scientist and entertainer. So it's a roadmap of it.
It's an interesting factor there. Dr. CARESUMMIT coming to regulatory management. So with CDSCO regulation evolving India 2017 implementation and how has the e-commerce landscape changed your company, your operation costs and timelines? And do you see regulation as a barrier or ultimately a brand builder? What's your take? What's your perspective on this?
Regarding the regulations part, the international regulations have been stringent and it's very different for each country. Suppose it is USA or EU, everywhere the regulations have been different. Even in India also the DCGA has a lot of different kind of regulations. But regarding the regulations being a brand builder or not, so if our product is a mid-sized product where the niche is very low and the requirement is very high, in that sector to say, in case if the regulations are very stringent, that will give a very good quality product out and it will be something like a premium. So in that case, the regulations help as a brand builder. Whereas in other niche where the product is a very easy product, very easily available everywhere and we have a lot of competitors, then in that sector, the regulations will have to be more stricter to get a good quality product. That is in a market with a very large. Whereas in a mid-sized market or a very small-sized market, the regulations have to be a bit loosened to get a very premium product. So that is what is we think. And now to say Indian regulations for medical devices have been more easier or more better compared to previous. Also the regulations, the quality, it has more challenges because in India there are no quality professional available. So whoever is there in the regulations officers or whoever is there in the manufacturing of devices, the quality check controller of the regulations and all the other regulations team that has not been so profound in India compared to the Western population. So that is the reason why when Indian product goes to other countries, compared to Chinese product, Indian product is seen not as a good regulatory thing. So that is the reason why EU and USA have a lot of other guidelines and it is very difficult to break those guidelines.
So that's the regulation part. Dr. Vivek, I'll come to you in a minute. Dr. Anmesh, talking from clinical quality and adaptation of the devices. So one of the biggest challenges for any new diagnostic devices a clinician faces or we face is earning the trust of fellow clinicians. So how did you approach clinical trials, peer validation and getting your neurosurgical colleagues to actually use and endorse the device you well?
We are the toughest customer for any company. Clinicians are toughest customers because the role really understand the beyond this kind of, because in my perspective we come up with the data. We don't understand if the product is good, everything is working fine, no. In my perspective we came with the data on validation, so we have validated this product on 120 cohorts and we have given the data, okay, this is the validation from the MRI, because my product is the cohort replacing the MRI and CT scan, right? So we have validated that product with MRI and CT scan and we have shown the data to my colleagues. Generally they believe in my product. As a colleague, okay, they can do tests, but they don't really believe the product. But my perspective is from the entrepreneur point with the product side, not the clinician perspective. That's where we face the challenge initially because the first test is very biggest challenge for us. Because this is a new product and no one really has adoption to it. And as you are the big players already Siemens, Philips, everyone is in the market, so the CT scan MRI can already in the market. But this is a completely new product, adoption is the biggest challenge and also the data correlation. That comes a long way, but we have already cleared FDA and all CDC. That's where there are kind of what we say like 2x work.
Dr. Vivek has a founder what regulatory improvements would make device adoption safe? What do you think?
So basically when we are looking for a new device, we look at the first thing is patient safety and the regulations, the government regulations, and the most important is monitoring equations also we look into that because when we think about business construction, so we are thinking about that. That when we take a new device, the ease of using it, the skill training provided by the provider. So we look into such things and we mostly if you want to talk about these things, we recently got a ventilator into a hospital. So for that we needed a good brand, looking for a good brand, good company. So we're still searching for a thing which is patient risk reductions.
Dr. Tejaswini, let's talk about how to sell Make in India products. So, export is the new frontier for Indian medical device manufacturers. What are the certifications, perception, and distribution challenges you face when trying to enter markets like Southeast Asia, Africa, or even Europe? And what would a genuinely export-ready Indian medtech industry look like?
As I discussed regarding in the previous question, so most of the Indian regulations or Indian products are not easily scalable in other countries. But to say the cost is very effective when it comes to Europe market or any of the Western side market, so they mainly give importance to quality. So they think the quality for the Indian market, whatever Indian product, if it gets at a low cost also, the quality is difficult. But as to say a pharma or medicine, whatever is there from India. So a pharma sector from India, a new molecule which is formed in India, that is taken up as a brand in Europe. Whereas that is not the picture for medical technology or any of the medical devices. So this should match on par with the pharma industry. So to have that, so the medical technology in India, the regulation should become more stringent. The quality of the product should be more applicable, and also the pricing should become higher to say. Because Indian products being at a very low cost in other countries, the perception is the quality is less. So when we increase the price of our product in other countries, might be that should give a perception of having increasing the brand image of Indian product also. That is regarding the product in Europe. Whereas in other countries like Southeast Asia, Indonesia, Taiwan and other countries, in those countries the medical devices or medical equipment, whatever is prepared in India, they would be open very, they would be very open for that. And also for those countries, the cost effectiveness from Indian product is very great. So initially any kind of Indian product, because I've been towards a few of the other international companies from the manufacturing industry as a family business. So through that, what I have seen is Indian products, whatever is there, it is more approved in countries like Southeast Asia compared to companies which are in Europe, because the European regulations are the most stringent out of all. That is what is my perception regarding this. So to encourage that, most of the Indian companies, they need regulations from other countries. So all the countries are different and they are very costly for Indian make. So around 3 to 5 years for any medical device or medtech company, they have to leave seeing the profits. They should just try to establish a brand.
Dr. Vivek, that's outside India, and we talk within India. What do you think device manufacturers can better engage with local physician associations like ILD? What are the criteria or steps they should take?
Yeah, basically associations like Indian Medical Association is like basically union of doctors association when they get into touch with these companies like product manufacturers, I think the product manufacturers getting touch with the people that CMEs and SP clinics actually.
Dr. Anish, can you talk about scaling?
I want to add here, because we do have a program, because we are a member of CII, okay? So we do already include the program called skill development with the medical professionals in relation to the manufacturers. So we have made a skill development program as an agenda, so that doctors can learn entrepreneurship and also entrepreneurs can understand the pains of the doctors. That's the brief we have come up with the CII. We are a healthcare panel member, CII healthcare member. Dwarkanta and also the Romani service having taken care of everything. So Kim said, okay, so we have a special program from IMA itself.
Did you get?
Yes.
So when we talk about scaling clinical innovation, this is to Dr. Anish. So your device solves a problem you encountered firsthand in a specific clinical context. So how do you think about scaling it from a single-use innovation to a product that works across India's varied healthcare infrastructure from AIMS to a district hospital in remote region? How do you want
Yeah, basically we have developed top-down approach. Ground-up approach, because the thing is like AIMS, everything they have well equipment and everything, but tier 2, tier 3 they don't have equipment and everything and don't really understand the technology. So we have adopted other way around. So we have built a solution stating that even from the doctor in AIMS can able to see and structure and diagnose from the in the tier 2 disease. That is what we have built, and it's a completely AI and IoT based device. So it's as you are aware, next part what we are doing is the brain-to-brain communication, where the defense ministry we have a project already upcoming, taken a project that. So we are reducing the training period of the soldier from years to the months. So using that we are upcoming trend. What about this? So we are seeing the perspective from the patient side, because we are a clinician. And also we can understand the pain from the clinician side. So the other way around, so we are into this ball game altogether, and we are completely into this perspective. So we are coming up from the ground up approach instead of up down.
That's the from innovation to industry from Dr. Tejas to Dr. Vivek and Dr. Anish. Thank you, panelists, for this wonderful insights. I request the organizing committee to facilitate panel members. Dr. Rajkumar.
Wait, once again. Ready, madam?
I request Dr. Raghu.
I invite Dr. Priya to felicitate Dr. Saroja with the moment.
నేను ఇక బయటికి పోలే ఏమైంది
పోతే పోతుంది
ఆగమైంటున్నా
ఆగమేం లేదు కానీ
ఏమైంది
అయిపోయింది ఒకటి అయిపోయింది అలా ఇంకొకరు వస్తారు మళ్ళీ
ఇప్పుడేం లేదు
now we have a startup which will be showcased by Mr. Balram. So I just wanted to give us some introduction regarding it. So most of the people think of global capability centers to be an extension of a country's division of the global corporates. So only corporates with money could build the country divisions, even startups, academic institutions, and the conference organizers with the inspiring mission of grassroots globalization, which is a generalization of the activities of reaching out to tier 2 cities, can also build the global capability centers. Adoption of the technology brings access to the global investment. So this is the integrating disruptive innovation. So according to the lessons from COVID-19, all we have learned as WHO has failed miserably in handling the COVID-19 pandemic, global healthcare thought leaders are exploring alternatives through the G20 national platforms. So this year, America is heading the G20 nations presidency. Healthcare is one of the most important tracks on the G20. Global medical tourism industry is being designed on the foundation of the visions of AI, digital transformation strategy, global capability centers, and the vision of institutionalizing, of democratizing access to global investment for the doctors and hospitals. So we are partnering with Mr. Balram. He helps us with explaining regarding the global incubation centers. So US Global supports institutionalizing of democratized access to global investment for all the industrial segments and sectors of all nations. And it's an academy of global business advancement. It's a research collaboration platform between reputed global universities and academic institutions of emerging markets such as India. So let us invite Mr. Balram Varnasi, PMP, MS in USA, PhD in USA, Global Development Partner and Grassroots Globalization Strategist, US Global Business Forum and Vice President, Global Academic and Entrepreneurship Partnerships, Academy of Global Advancement, Founder and CEO of Project Management and Digital Transformation Strategy Consultancy Services. So let us invite him over the stage. He will be explaining regarding what is this Global Incubation Center about and how is it beneficial to all the doctors and healthcare community. Let us welcome him. Thank you.
Good afternoon, everyone. First of all, presentation. I would like to thank Dr. Manaswani Garu for inviting me to this conference. And I'm really delighted after I had a brief conversation with Professor Dr. Bhaskiran. He has offered me a speaker slot. I'm really delighted to be with medical practitioners. This is my third opportunity to be with medical practitioners. The first one, I had the privilege to be with, North American Telugu Association. They were organizing a conference in association with Apollo Hospital, 2-day continued medical practice and all. And the second opportunity was Vitsikilani, Hyderabad, American Association for Precision Medicine. They were organizing 1-day conference. So I had rough idea what to expect from doctors' conferences, and I have preparation for that. The topic today is Global Conference Capability Centers and Global Academic Capability Centers. If you look at, we see in the news, about 2 GCCs are coming to Hyderabad, all those things, right? How is this vision of GCC useful for doctors, hospitals, and the medical tourism industry, and for tier 2 cities? See, now everybody in India policy, they are thinking that GCCs will also be in the metro cities. Okay? This GCC architecture, it is not a country division with the headquarters or metros and all. This GCC is like an internet server design where the international global quality internet components will be in the tier 2 cities, and this component internet server will be in the metro cities and the global cities. So I would like to focus on that. I have my own Ujjam registered MSc called Project Management of Digital Transformation Strategy Consultancy Services. Through these, I offer services for the doctors, startups, healthcare operations like that. Next one. Go ahead. So the objective of this presentation is, normally in India we experience knowledge impact conferences. That was the situation. Computer Science, Computer Society of India, CSI, used to have like a lot of conferences until 1988. When London Village started, we have to have a business impact association like that. That is the origin of National Association for Software Services Companies, NASCOM, right, which created the foundation of the global IT industry we are so proud of, that brought global recognition for India, for global excellence. Until then in America, other countries, people were thinking like India is like a father, some creeds, some straight charters and all. Our image as IT industry has transformed, our image. They have gotten foothold in all the, corporations worldwide. And based on that, we are able to extend our partnerships, like that. So, the next previous one. So the focus is on transforming the knowledge impact into augmenting knowledge impact with global business impact, global investment impact, and global industrial impact. What would differentiate a tier 2 conference and highly esteemed conference, an MIT conference in a top city in America? What would be the difference? Knowledge impact. There are like high quality people are coming, but with the doctors here also, like state of the art we are discussing. But the impact, the utility of participation in the conference for the sponsors, for the individual delegates and the doctors, hospitals, it is value engineering. That aspect I would like to bring to India. Okay? And improving the readiness of the delegate sponsors. There are like a contemporary industry paradigm like AI readiness, global capability center readiness, global medical tourism readiness. Rather than each of the hospital doctor trying to figure it out on their own, I am building a common tool, that this should be added to each one. This would improve the ease of compliance with the global standards. This is based on award-winning research. I received an award from Mr. Gregory Balestero, CEO, President of Project Management Institute, America. This is based on hybrid global enterprise, server enterprise technology. All of us know virtual enterprise, virtual conferences. Yesterday we have seen some speakers speaking from, technology is available. Why don't we doctors across the, technology is available. Why don't we doctors across the region case form, okay, in real time? That technology allows, and we would like to partner with MEDIEDGE and some hospitals to build the functional prototype. Unique selling proposition. I'm a certified project management professional. I can live by offering project management services. I can live by offering project management services. My unique selling proposition is, for the cost of project management training, I can provide AI-generated digital transformation strategy roadmap for either a doctor, hospital, like that. That is my unique selling proposition. Next one. I am formally appointed as Vice President Global Academic and Entrepreneurial Partnership for Academy for Global Business Advancement. This is like a Dr. Kyle Chairman Board of Trustees of AGBA has appointed me formally in the Gala Dinner Awards function in 2024 in Thailand, Bangkok. And the appointment is renewed last year as well. Okay? The significance of this is ABBA is the initiative of Texas A&M University. I am Albert dissertation from Texas A&M University. ABBA currently does not have an endowment. But if I can champion creation of endowment for ABBA, and connect with all my global alumni like that, this provides me a platform for revolutionizing the disruptive innovation like a global capability centers like that. Texas A&M had about 400 study abroad programs from 110 countries. Okay? And annually, in about 300 cities, graduates meet on around April 20th or 21st like that. And we renew our work, we will make an impact on humanity like that. If by using the technology, if we build a global capability centers that create graduates as the project team leader and study abroad aspirants as the project team members, these concurrent projects I can launch. I have based in multiple countries. What is the advantage Facebook, like some of the leading, companies got? They are graduates from reputed university. They are like in the hometowns of innovation. However, if you build these global capability centers, the graduates, like from American universities, living in Hyderabad, China, they used to, launch their product services with equal power. For example, I have seen yesterday Doctrine. Okay, this is a social media platform. If we launch, across the platform, this innovation, that is one of the things that we easily do as a demonstration of application of our services. Okay, next, please. Next. I am also currently serving as a globalization consultant for US Global Business Forum. This is a business and investment forum based in California. The vision of Mr. Kevin Cow is global peace through global trade. Okay? So, if you look at when the USGPF was started in 2006, the challenge was only in about 14 countries. How to get FDI, governments know something about it. Rest of the all, maybe 195 countries are affiliated with the United Nations. FDI access was through corporates only. They do not, none of the government does not know how to get the FDI access. So US Global Business Forum champions the cause of making FDI access available to all nations affiliated with the United Nations. That was the original charter USGPF was founded. I am interested in how do I extend that to saying like a institutionalized, democratized access to global investment for all the states, for all the academic institutions, for all the tier 2 cities, tier 3 cities, villages. In the vision of regional global center, earlier we were thinking only Hyderabad, Kokapet, not thinking, these regions will develop. Now the regional ring road, it is like all tier 2 cities and villages are also connected with a high speed, road transport and all. So we would like to look at the models how Europeans and all, they have internet allows people work from anywhere standard where the doctors could be coming and staying in, Karimnagar. Doctors from America that I am talking about. That could be like a mentoring some of the junior doctors here like that. All such paradigms are technologically possible. And we would like to challenge the medical practitioners, why are we not adopting this technology, that technology, I can solve this problem, that's a problem like that. Next one. Okay, we see Dr. Tejaswini, she is like an entrepreneur in addition to be a doctor. This is a common trend, healthcare startups, everything. I am trying to bring the expertise, how the startup expertise, investment expertise, project management, digital transformation, and all the leverages like talent, global team, global technology, global capital access to all the startups, such that the quality of the outcomes that our startups, our healthcare institutions generate will be on par with the global excellence. Okay, so I am interested in creating single window for conducting startup and investment boot camp. So, for example, the startups that I have showcased in the MEDIEDGE, I could show virtually the startups in different academic institutions create project associates. So, what is happening in India versus how it is easy to conduct conferences in America is that imagine now we have Karimnagar conference. Imagine next conference in Guruvada, Andhra Pradesh. Imagine hypothetically you must conduct. Again, we are starting from scratch. Not necessary. From this conference, we need to recruit the project teams that will improve the ease of conducting the next conference. And we have something called value engineering. What is the value of participation for each delegate, for each sponsor, for each hospital, for each consultant, like that. Once we start designing and improving the value, what happens is suddenly there will be viral effect where we don't have to push this trial vision and all. There are requests from all over, like my city have this conference like that. I am into that is the benefit of strategic partnership with our organization. Next one. Academic partnership. My role is Vice President Global Academic and Entrepreneurial Partnership for Academic for Global Business Advancement. In 2010, I have submitted, I was at that time only founder of Philosophical Society of Perspective Independence, only NGO that I have created. I am an American graduate rated like that. I have submitted for, there was a program called Board Fellow Program at Indian School of Business, Hyderabad. I asked for, they were offering course graduates of students of ISP, okay, to research the feasibility of the problem, 40 hours each like that, okay. So the team led by Mr. Saurabh Goyal, DC list in 2010, I offered why don't I present the successful entrepreneurs from ISB as a single window for all the affiliated colleges of JEB. I just proposed a very social responsibility model. And I got like 160 hours. I have been variously there from the JEB, lot of due diligence we have done. At that time we got supply Telangana crisis, therefore we missed the connectivity and all. However, now with my ABBA platform, this has like 50 countries, like multiple cities, for about last 20 years, so many academic institutions are participating. Imagine I will start showcasing the startup with my MOU. I have an MOU partner of ABBA. I created ABBA Global Leaders and Enterprises. I co-founded it along with Dr. Jafar Ahmed, founder CEO of ABBA. Our model is, I can present a startup if it is feasible for me to entrepreneurial associate to generate business for a hospital or something. I can generate that from any country worldwide. Okay? That is the single window access it is going to leapfrog the Indian development. Okay? So what kind of partnerships can academic institutions have? Medical college is also a college, right? You are also facing like a skilling issues, like technological advancement is really fast, adoption is not matching up with the advancements like that. These are all industrial engineering solutions are there. I am all but dissertation in industrial systems engineering. Okay? And the executive education partnership, experiential learning project, program partnership, investment partnership, incubation partnership, admission placement internship. So basically what we are proposing is, when an academic institution is part of the global academic internet, okay, global teams of experts are coming and like say NRI doctors coming, reviewing the local facilities, benchmarking with American infrastructure like that, some programs like that. when they benchmark, when they are creating a possibility of raising the American investment, does not matter. I can build a high-class facility in Karimnagar. Okay? And when I do that, that is when you get the medical access, medical tourism access. Okay? Next one, please. My educational qualification, as I mentioned, I am all but dissertation for Doctor of Program in Industrial Systems Engineering. If you look at medical tourism is an industrial system. Yesterday, we were talking about intelligent hospital. Intelligent hospital is a perception. Somebody could say, like a hospital that gives profit is a intelligent hospital, something like that. However, smart cities driven MIT, these are all data analytics driven. That's a technologically driven vision. Now there is like a smart enough city where they say put people first. Look at, I can offer a global capability center. Rather than pushing global capability centers to hospitals, doctors and all, we want to give doctors to the hospitals to articulate what are the challenges, what are your aspirations. This should be the first. Okay? And aligned to that, my technology adoption, expert transmission, exposure graph, standardization, steering company, standardization company. That's how the global standardization can happen from Hyderabad and as well as from Karimnagar. This is the biggest possibility made possible through Washington account. Earlier, we are only standardization user. Now we can be global standardization leader. We have taken it up and we need the support of all of you to build a standard from India that will be adopted, among all G20 nations. This is a big ticket, high hope for the, we need partnership of, MEDIEDGE and all other, partners. I'm really delighted to see, global leadership of doctors. Yesterday there was a conversation about leadership. If it is just a continued medical education, that is like a professional leadership. When you say prior to city, you have extended part in the global leadership thing. This is a really big thing, like a small step for India, like a big leap for humanity, that kind of a global impact. Okay? This is the other program I think you have seen. Next one. Upcoming recommended global conferences. Recommended global conferences means I recommend through my project management digital transformation to attend an experience. Like global excellence do not come to your office. Only medical representatives will come. Some study abroad, student recruitment, people will come. If you want to really leader in medical tourism industry, something like that, you need to start participating in the global conference. And we are now, many people will be asking, do you have any success stories and all? For me to have success story, I have already, authored a self-publication like that. If I create a success story of 10 hospitals or somebody who has benefited with my global capability center, I'm going to publish and make it available in all cities global. Okay? Now, like a beta phase, we are inviting those who would like to experiment. Protected experimentation means your investment in participating, we will cover that. How it is, we will discuss one-on-one. Okay? And also global conference of ABBA is in Malaysia, July 2nd to 4th. Here, there is something called, there is an academic conference and also something called Malaysia Miracle. It is a trade promotional leadership development conference. You need to, for medical tourism, you need to explore trade promotional leadership. You need to, like a trade commissioners, what they are doing is, they offer for bilateral trade of a country, they offer 1 crore rupees, like I'll conduct so many conferences in India, and so many conferences in, say, Malaysia, like that. The trade commissioners may not be subject matter experts like doctors. If you want a medical tourism to happen, we need to have a trade commissioner who is a medical expert. Okay? for that to happen, we need to first, we are offering like a trade promotional leadership development program. If you can recruit help us recruit delegates for that, okay, we will go there, Malaysia, America, India, Bharat, try interoperable standards we will design. And I am also going for some family office summit in June 12th in Mumbai. I am proposing, most of the time we don't have like a investment access. It is just creating some kind of structure. Imagine our investment access is not there. Probably take any investment to participate in the global conferences and you are done. Okay? It is just a matter of equity, some percentage, this or that, dilution, that's all. But don't think that India does not have the ecosystem and all. We design, customized solutions for you. Next one. Next. I am also founder of Leaders and Enterprises Aspiring Development India 2020. This has like about 6,500 members. Every year, these members I have gotten by presenting my vision. Then I have, in the offices of different other leaders, I conducted meetups. Now I want to, partner with MEDIEDGE, like a showcase the, leaders of this conference. 1 or 2 leaders as invited speakers. Multiple conferences happening concurrently in multiple colleges. And all the effort funnels to your next conference like that. Okay, I would like to demonstrate prototype. When I came from America, there was not even ISP in Hyderabad. You can imagine, I thought, oh my God, my life is, sacrificed like that, So, I first created Philosophical Society of Perspective Independence. I started working with unemployable graduates, created some spoken English institute in a partner there, survived. Then a project management professional from advancement. Then 2012, India Development Coalition of America started coming. Then 2014, I connected with USGBF. 2019, connected with ARPA. The more and more association and connected, we are getting more and more energy. Okay? So, I really believe that the partnership with MEDIEDGE will be like a completion, something like that, brings all the effort to fruition. Thanks. Next one. Okay, contact information. This is like a, like a some kind of call for action in social media when you say that, right? Contact information, it is like a passive presentation. I pulled copied this from student presentation. Okay? So I am really inviting, note down my address and okay, we will be definitely working with Professor Rajkumar and all. But if you really want to be a part of this global leadership effort, you need to take initiative. We will definitely do, but you may not be there in the team. Okay? So I invite you all to be active, contact me, contact Professor Rajkumar. Thank you very much for being wonderful audience. And also, speaking with, discover, connect, transform. Discover, I discovered MEDIEDGE and MEDIEDGE discovered our services. Now we have connected. Next step is transformation. Access to transformation is, authenticity is the access to transformation. Look at, like our thing is in YouTube. But how many people are actually viewing on YouTube? I have checked, Dr. Rajkumar has sent me the link. 2 people viewing, 2 people like that. That should be like hundreds of thousands, millions like that. Okay? I thought that this is the first edition. You manage so many things, it is wonderful. We need to, for the second edition, we need to have service level agreement, at least 10,000 online viewers should be there like that. Okay? And the restoration of integrity, we need to, we are used to telling, almost like a first student, I provide you knowledge, take it like that. It is time for us to start. If we want to build a global capability center, we need to invite the best talent of America and say, this is my practice from? Where is that I am missing? You need to proactively invite, okay? Invalidation. Tell me, like benchmark me against the global thing. Show me where I am lacking and all. Once we have authenticity, there are programs, global investments and all that. Okay? That for transformation, let's all be authentic. Let us hope for the best. Thank you very much. Namaskar.
Thank you very much, Dr. Balram Garu. You came all the way from US to Hyderabad to Karnataka. So, thank you, and we are very much privileged with your talk, and you blessed us, and our MEDIEDGE will definitely, our theme is discover, connect, transform. That is the reason you explained it very nicely. Thank you very much. I request Dr. Raghuteja to felicitate Balram Garu.
Cardiology 2.0 means less invasive procedures, smarter stents, robotic catheterization, and data-driven treatment decisions. With this, our next panel session is on Interventional Cardiology 2.0, redefining the future of heart care. And to discuss on this topic, I invite our panelists, Dr. Anand, a consultant cardiologist at Avishai Hospital, Heart Care and Multi-Specialty, located in Siddipet. He is an alumnus of LIMS and Osmania Medical College. Dr. Anish, consultant interventional cardiologist at Medical Karimnagar. Dr. Anish had many publications and posters in national and international conferences. Dr. Vijay Raj Vijayendra, consultant interventional pediatric cardiologist at Vijaya Cardiac Care, Brainy and Brainy Hospitals. To moderate this session, I invite Dr. Krishna Chaitanya, cardiologist from Sri Chitra National Institute, Trivandrum. He is the head of the department. Currently, he is the head of the department and senior interventional cardiologist at Apollo Hospitals, Karimnagar. Over to you, Mr. Krishna Chaitanya.
Good afternoon, esteemed colleagues, ladies and gentlemen. Welcome to this session, Interventional Cardiology 2.0, redefining the future of heart care. As interventional cardiologists, our specialty has always thrived on disruption. We evolved from bold early days of old balloon angioplasty to the precision of blood-eluting stents, and then to transformative era of structural heart interventions like TAVI and transcatheter edge-to-edge repair. We have consistently pushed the boundaries of what is possible, turning highly invasive surgical diseases into percutaneous same-day procedures. But today, we stand at new crossroads. The transition to interventional cardiology 2.0 is not just about a new device or a thinner stent struts. It represents a paradigm shift in how we detect, visualize, treat and follow on cardiovascular disease. We are moving away from purely reactive anatomy-driven interventions. Instead, we are embracing proactive, physiology-driven, highly personalized care. The future we are entering fuses mechanical precision with digital intelligence. We are seeing AI transition from a research buzzword to cath lab reality. It is optimizing intracoronary imaging like OCT and IOS, anatomic plaque characterization and predicting procedural complications. So today we have esteemed panel to discuss about interventional cardiology 2.0. We have esteemed panel. First I would like to ask Dr. Anand. So cardiogenic shock and mechanical circulatory support is today a buzzword. So cardiogenic shock team approach is saving a lot of lives, especially in ER and cath lab. So there are many mechanical circulatory support devices like IADT, like Impella and EXPO. So how do we select these devices for a particular patient and personalize the treatment for the best outcomes possible? Can you throw some light on it?
Not the cardiogenic shock. What is the mechanism of cardiac shock? Is it simply left ventricular failure, biventricular failure, or failure with severe hypoxemia and increased lactate levels? So, if it is left ventricular failure, we can see a left ventricular assist device. It is provides the cardiac support, respiratory support, and it requires little surgery also at the bedside. And if it is only just hypotension, you want to support the coronary perfusion, you can do a Impella device. And depending on the mechanism, so if you want to, this requires a team approach. Like a cardiologist, heart failure specialist, cardiothoracic surgeon, intensive care specialist, and nurses. These all people, they decide what is it. So, if the patient is on inotropes, so if you are what patients you have to select for these devices. If the patient is on prolonged inotropes, requiring escalation dose of inotropes, you see, increase the dose of inotropes, are unable to wean off the inotropes, you are getting a fresh heart attack on a old heart failure, and or it could be a large annual MI, and even if it is a increased right ventricular MI also on the pre-existing disease, then you have to get alarm, you have to escalate from the normal MCS, which is called as circulatory support. And you have to go for the next tier of devices. First one is left ventricular assist devices. So that can be done at the bedside also. But if you are, this is Impella left ventricular assist devices, which requires a surgical support, which increases the aortic blood flow. You bypass the left ventricle and increase the aortic blood flow. So it requires a cardiac surgery. If you are taking up IABP, that can be done at bedside. It increases the diastolic blood pressure, and if you are the recent concerning about ECMO device, how are you implementing the ECMO devices and what are the use, and it is a veno arterial circulation will be there. So definitely patient who has having a biventricular failure, severe hypoxemia, acidemia, now modalities are there, we can use it for the next devices therapy.
As you rightly mentioned, the mechanical circulatory devices are chosen based on the stage of the shock the patient is on. I classify the patients in the shock as ABCD or arbitrarily in emergency and decide whether the patient will benefit from IABP or Impella or BAMO depending on the clinical criteria we have. So, thank you, sir. Dr. Anish, as a interventional cardiologist, managing so many coronary interventions and doing coronary imaging, OCT and IRS have benefited significantly, especially in patients who have ambiguous lesions, whether the lesion is hazy or the patient is having a vulnerable plaque which is supposed to rupture, or patient is having indeterminate size of lesion, or patient is having significant concentric calcium or eccentric calcium, and to devise the strategy for intervention and to do precision PTCA, OCT and IRS we are being using. So, but significantly this intravascular imaging is mostly centered around the metro cities. So, how do we increase the adoption of intravascular imaging to do precision PCI, to prevent stent failure and to give best outcomes for a patient? How can we increase that adoption in peripheral also?
One thing is that OCT IOS, the usage and its advantage are established, not to discuss much about. But the main issue is the availability, especially when it comes to type 2 cities, it's easily available in metropolitan cities. But in our place, if you want to plan, it's at least a 2-day procedure. You have to speak with the person. RFSG hospital, but there is a way which is not covered under RFSG, and many of the patients are not affordable for it. It almost costs 1.5 to 2 lakhs extra just for the basic procedure. So that is the economic issues we are having. And one more thing is that we need to inculcate the idea of that this is not made for so cases. For example, we can follow the Japan Korea model where they do any complex OCT IOS only. Without that, it's like won't use an OCT or IOS for a complex lesion. It's equivalent to mandatory. We are literature. So we have to get that idea into our cardiologists that it is mandatory for this complex cases. And one more thing is that it's already established. We have to use so cases, everything as you mentioned, sir, it's established. The thing is availability. So one more thing is we can't buy the machine and keep it in our center like in place like Karnataka because it's costly. And to retain it, at least we have to do one procedure per day. It's not possible. So what to do for it? We have to, my opinion is we have to talk to the company person, make it more available for us. Point number one, because of the availability, we have some hesitant to advise to the patients. It's available, definitely use more. And one more thing is that we can use better machines now. The MEDIEDGEHEALTH company is starting system where a single machine, single catheter is useful for both IOS and OCT. By doing that, we are cost cutting, we can use anything we want. We can get near tissue histology or we can get also deep and precision types. Both are possible, the same catheter and the same device. If we plan such way, we can bring a machine or else all cardiologists in Karnataka we can bring one machine for us together and we can rotate it around our centers. So that it will be helpful for us. One thing, availability. Point number two is economic crisis. Both in reason the surplus like in the form of insurance or decrease in the cost. You can definitely increase the usage of fibers. And one more thing, we have to get an idea
We need to go to immediately in NICU care. We need to monitor saturation. As the saturation falls, we need to start immediately prostaglandin and plan for the ductal stenting. So ductal or any other balloon dilatation, aortic stenosis, if duct dependent lesion, ductal stenting. So by this, we will be knowing the clear cut what is the diagnosis and what is the prognosis. Most of the cyanotic heart diseases and most of the cyanotic heart diseases which are biventricular physiology, the outcome is around 90%. The lifetime will be almost 90% as expected as the normal people. So always have a clear cut targeted imaging, fetal echo, and we need to diagnose early and we need to intervene early in the congenital disease.
To summarize, it is very useful in first time diagnosis.
Yes.
Patient family awareness,
Awareness.
and the doctor itself can prepare for the required procedures.
Yes.
And if it is life-threatening, to intervene early and save them.
Yeah.
How do you think will be the long-term outcomes of these patients?
So in acyanotic heart disease, the outcome will be as good as the normal. The life expectancy will be as good as the normal people. In cyanotic heart diseases, which are biventricular, mostly they need one or two surgeries. Biventricular cyanotic like TOP, PAPVC, and some TGS. Mostly they will be having one or two surgeries throughout their lifetime. If requiring single surgery like PAPVC and PGA, they will be having near normal. So when we go to the single ventricular cyanotic heart diseases, they need lifelong follow-up. The life expectancy will be less compared to the general population. So in the second and third decade, they start developing conditions like protein losing enteropathy, liver fibrosis, and other things. So this, the single ventricle, if we go for the single ventricular pathway, Glenn and Fontaine, they will be having less life expectancy compared to the others.
Thank you, sir.
Complications like protein losing enteropathy, liver fibrosis, and other things. So this, the single ventricle, if we go for the single ventricular pathway, Glenn and Fontaine, they will be having less life expectancy compared to the others.
Thank you, sir. Dr. Anand, when it comes to cardiogenic shock and mechanical circulatory support, the outcome of the patient is determined by the peripheral circulation, like you said, the maintenance of tissue oxygenation and the monitoring of lactate levels. Whether the peripheral centers can act as a hub and spoke model by early diagnosis of cardiogenic shock, explaining the prognosis to the patient and patient families, and then referring the patient to the higher center for better management of cardiogenic shock. How does you think that strategy would pan out?
Definitely, peripheral centers can act as a hub. They can diagnose the cases which are not recovered cardiogenic shock, and they can refer to higher center. They can have a 24 hours referral network also. They can monitor with the higher centers regarding the patient blood pressure, number of iron probes, escalation of the iron probes, and what is the exact cause of renal failure, acidemia, lactate levels. And if it is not increasing, you can wait for 24 hours, you can wait for 72 hours. More than 72 hours, it is not improving. Some reversible causes are definitely there, like myocarditis, alcoholic thing. It is not improving. Some peripheral centers we can even do things like target weather reclassification. We can do it at centers, like PDCA, for the target weather before going to cardiogenic shock. And if patient not target weather reclassification is not advised, and if the patient, if you suspect the approval MI or something, you can even go for the thrombolysis with the newer thrombolysis. But if the mechanical complications are settled, then we can ask them for the surgery. But if there are no mechanical complications, then we can act as a help, counsel the patient and refer to the higher center, because therapies are there, newer modalities have come where we can have the bridge, stabilization bridge, so that some may go for transplantation and some may improve the bridge therapy. So definitely we have help.
Thank you, sir. Anish, when it comes to chronic total occlusions, we have various armamentarium of different wires, anti-grade approach, retrograde approach, subintimal approach. So many new technologies have come to go to subintimal and come back to the intima. So how far these chronic total occlusion interventions help the patient, and how to bring about the awareness about chronic total occlusion procedures in the patients?
While dealing with chronic total occlusion patients, first thing we have to do, the main target of any cardiologist is to see for the quality of life. Whether it is being maintained on optimal medical therapy, is these factors are being managed appropriately or not, and if it is fine, the CTO will be left alone. But if the patient is having, in spite of optimal medical therapy, refractory angina, the patient is still showing of more than 20% of PET CT or cardiac MRI, or else the patient is having a debilitating disease or liver dysfunction, then we can plan for going for then we can go for open revascularization. But the thing is that whether the optimal medical therapy is achieved or not, first we need to monitor that. But in our case, main issue is blood complaints, cost of the medicines, the patient is appropriately taking it or not. If he is able to take it, okay. But majority of patients will question us, how many days I should take this medicine? Am I supposed to use it forever? But these anti-angiogens are costly. The same thing happened with ischemia trial. When the drugs were given to all the patients properly, the patients were good. But once the trial ended, everything was done. What happened is that the patient, almost each and every patient underwent PTC afterwards because drugs were not available for them. So the thing is that the patient must take the drugs, he must be on optimal medical therapy, then they will be stable. But it's not causing our setting because there's a costly drugs they may use for 3 months, 6 months, but after that they will stop it. My take on is that it's better to open the CTO, but we should explain the complications like more risk of perforation, more risk of going to risk of emergency CAPG during the procedure, more contrast exposure, more expenditure also. When with the doctor-patient discussion or explain the drug therapies, everything, then we can go ahead with the CTO management and better to evaluate properly prior, like in the form of we can go for CBCAG or a viability scan. Everything must be done. If the scar is not there, it's viable, then we can go for CTO after proper patient and doctor discussion.
So to summarize, we have to take a R-team approach, discuss with the patient, pros and cons, patient benefits, we will go ahead. If the patient doesn't benefit, we will keep him and motivate him to be on optimal medical therapy. Thank you. Dr. Vijayan, sir, so many patients proceed and improve with the management of congenital heart disease after the procedures are done, whether it may be intervention or surgery, from pediatric congenital heart disease to adult congenital heart disease. In US and Western European countries, there is a separate specialty for adult congenital heart disease. So there is a transition from pediatric congenital heart disease patient to adult congenital heart disease patient. The hemodynamics and the management may differ, and the necessary actions have to be taken. So, is there in Indian setup, is there any need for that additional branch or specialty of adult congenital heart disease, or to transition from pediatric congenital heart disease to adult congenital heart disease? What is your take on that?
So definitely there is a need for adult congenital OPD. So adult congenital OPD, in my opinion, should be collectively done by adult cardiologist along with the pediatric cardiologist. So in pediatric, when we do any intervention or surgery, If there is no residual lesion, usually we will follow up to 3 to 5 years. There is no residual lesion like ASDP, DSD, device closure. There is no residual tricuspid or aortic regurgitation. There is maximum recommendation is around 5 years we have to follow, and maximum up to 10 years. So after that, there is no need of follow if there is no any residual lesion. When we are talking of residual lesions, suppose top, they will be having pulmonary regurgitation or any single ventricular lesion, they will be having so many complications with the single ventricle. So in these cases, there is definitely need for the transition care, and there is definitely need for the adult congenital clinics. So in this transition and in adult congenital care, we need to make the tailor-made treatment for the weight in transition period and then go for the adult dosage when they reach around 21-22 years. So there is so much gap is there in our country. The adult congenital is so much neglected in our country. Like so many patients we are seeing with pulmonary regurgitation, bicuspid aortic valve, aortic regurgitation, mitral valve prolapse with mitral regurgitation, and as we all know, the rheumatic heart disease also starts from the pediatric group. So much lacunae is there in congenital disease treatment in our country. So we have to have a proper team with all the surgeon, pediatric cardiologist, adult cardiologist, go through this care.
Thank you, sir. So to conclude, I would like to mention that interventional cardiology initially started in 1929 with Werner Grossman, who has catheterized himself experimenting using a urology catheter into his right heart. It started in 1929, and in 1957 is the first angiogram done by Mason Sones, and then in 1977 the first balloon angioplasty was done, and then in 1985 was the first bare metal stent implanted, and 1999 was the drug-eluting stent implanted, and in 2002 Alain Cribier has done the first TAVR. So in the last almost 100 years, interventional cardiology has come a long way, but we have to transition to the 2.0 and a patient-centric personalized care with using AI and other technology for the benefit of the patients. Thank you. Thank you, Anand.
Thank you very much, sir, for wonderful cardiology panel. Now I request Dr. Tejaswari to give memento to Dr. Anish. I request Dr. Tejaswari to hand over to Dr. Anand. I request Dr. Lakshman Kumar sir to hand over memento 5 minutes, Alasha Hospital, Dr. Sandeep sir. 5 minutes. We start in 5 minutes.
Ladies and gentlemen, what you just witnessed is exactly why MEDIEDGE exists. Not to talk about change, but to show it, to celebrate it and to amplify it. Adarsh Hospital has shown every hospital, every doctor, every healthcare entrepreneur in this room that it is possible. That if the will is there, the way will come. Today Adarsh Hospital saves future lives, not metaphorically, literally. Somewhere out there is a patient who doesn't know yet that because of which happened in this room today, they will survive. Congratulations to the entire team at Adarsh Hospital. Karina is proud of you, and MEDIEDGE 2026 is also proud of you. So I would like to invite Dr. Sandeep sir to explain regarding the CRRT product which they are about to launch. Thank you.
Good afternoon. I am Dr. CARESUMMIT, working as a consultant nephrologist at Adarsh Hospital. At the outset, I would like to thank MEDIEDGE organizing committee for giving us the opportunity to discuss a few things about acute kidney injury and CRRT. So what this presentation covers is, first I just go brief into AKA. What is the criteria, what is the staging, and then how to just a brief one slide about evaluation of initial evaluation in the ICU, and then when to start our renal replacement therapy, because we get calls, sir, creatinine is 4, should we do dialysis? So we just discussed a little bit about this, and then a small mnemonic of AEIOU in AKA. So coming to the definition, AKA is defined as diagnosed by a rise in serum creatinine of increase of 0.3 milligram in the last 48 hours. So if a small increase in creatinine is considered as AKA. It's also diagnosed with, you can also see if the baseline creatinine is there. If suppose baseline creatinine is 2 and 1.5 times, if it becomes 3.5 in next 1 week, it's also diagnosed as AKA. Or if the urine output criteria, the output is less than 0.5 ml per kg per hour for 6 hours, it meets the diagnostic criteria. And we have the other criteria like Rifle, Akin criteria which are used for staging the AKA. So how to approach to AKA? Whenever you see a patient is diagnosed in ICU, you label it as AKA. So first you need to think about the perfusion, like what is the mean arterial pressure, what is his blood pressure, what is his heart rate. You have to assess his volume status, assess his blood pressure. Is there any evidence of sepsis, any reversible causes, any nephrotoxic exposures? Now you see this this heat wave, you are seeing a lot of heat exhaustions where the patient is already on telmisartan, and then now he has got exposed to severe heat. So creatinines are jumping from 2 to 6. So those are those reversible causes that we need to look for. And then just look at the folies. If patient is catheterized, look at the folies, look at the color of the urine. That will give us, color of the urine will give us the picture of what is going on with the kidney. And then see for the complications like any hyperkalemia, metabolic acidosis, volume overload state like pulmonary edema, or any other uremic symptoms. So dialysis started for complications, not for creatinine. So the category recommends emergent renal replacement therapy when life-threatening changes in fluid, electrolyte or acid-base balance are present. It's not based upon the creatinine. There is no certain creatinine value more than 6
do dialysis, more than 5 do dialysis, more than 3 do dialysis. It depends upon the complications. Next. So what are these indications? Just a small mnemonic. AEIOU, acidosis, electrolytes, intoxication, overload and uremia. Acidosis, we all know severe metabolic acidosis is common in renal failure and sometimes in lactic acidosis can be sepsis, severe sepsis. And then electrolyte disturbances. Main common is hyperkalemia. You know the ECG changes in hyperkalemia and the cardiac disturbances. And then drug intoxication like ethylene glycol, ethanol, lithium, they are all dialysable. Even salicylates are dialysable. Volume overload state, the overload state, acute pulmonary edema. And then the last one is uremia. If patient is in uremic pericarditis, uremic bleeding tendency, that's also an indication. So you can remember this AEIOU. Next. So these acidosis and electrolyte emergencies. Again, we need to consider renal replacement therapy when there is severe metabolic acidosis, and usually we teach threshold is about 7.1 to 7.2. But again, the decision remains clinical. Yesterday, Dr. Praveen is here. We have seen one patient with pH of 6.9. We managed conservatively. Then electrolytes, hyperkalemia. The same patient was having potassium of 7. Now it is around 5.2. Next one. So again the same intoxication, overload and uremia. Next one. So we need to, for this is a practical decision pathway, we need to confirm the AKI, stage the AKI, and then treat the hyperkalemia, metabolic acidosis, shock, sepsis, any obstruction, basic thing. Sometimes you know in the side railing of the bed the catheter gets stuck in the side railing of the bed. So you just lift the side rail and the patient has a good output. And then indications of dialysis and when to start, we'll again discuss it in the next slide. So a lot of critical care specialists argue here when to initiate the dialysis, early versus late, whether early within 24 to 48 hours or after 72 to 90 hours. So there is no mortality or morbidity benefit if started early or late. And if you see the recent meta-analysis, early initiation increased RRT associated adverse events. The events secondary to the catheterization, bleeding, the hematoma at the catheter site, or because of the dialysis related complications patient has undergone. So it is again based upon not upon creatinine but on the complications of the situation. The next. So when to choose what dialysis to choose? Next slide. So we have this intermittent hemodialysis, sustained low efficiency dialysis, and CRRT. So we can say probably that Adarsh Hospital is the only hospital which has all the types of extracorporeal therapy. We name intermittent hemodialysis, sustained low efficiency dialysis. We have a separate machine. Many of the hospitals use the same machine for both, but there are differences between each machine. The next slide. So again, we have this tabular form depicting intermittent hemodialysis, sustained low efficiency dialysis, and continuous renal replacement therapy. So SLIT can be done for 6 to 8 hours or maximum of 12 hours. But again, you get a lot of complications in the while doing SLIT. So thereby the clearance will not be good. But whereas with CRRT it's a 24 hours, we can do it for 24 hours, we can do it for 36 hours. The longest we did in Telangana was almost 40 hours we did. And we can do it with a blood flow of even 50 ml per minute. Even if the patient is having a BP of 80 or 90 systolic BP, we can try CRRT. And it causes the least hypotension. But again, complications here, thrombosis is there because of the low blood flow, so thrombosis is common. Next one. So this is the dialysis circuit, which we know. The next one. So this is a live example. The next one. So this is what I was talking. This is a new machine which we have in Adarsh Hospital. This is SLIT. This is different from CRRT. So this for this at least MAP should be above 80, and we can do for 6 to 8 hours, maximum up to 12 hours. Again, poor tolerance to intermittent hemodialysis. Patient is having fluid overload. we can't remove the 4 liters of fluid within 3 hours or 4 hours. We need to do for 6 to 8 hours, especially post cardiac surgery cases. And then severe metabolic acidosis, we need to do the dialysis for a longer time. But whereas patient is not affordable for CRRT, we can go with this machine. And then encephalopathy, because we need to clear slowly. Again, if there is rapid clearance of the solutes, you have the patient can go into disembalances. And then there will be urinary pericarditis also. And in liver failure, when there is hyperammonemia, we can do this slide. Next slide. So again, we have based upon the patient's hemodynamic parameters, if there is instability, CRRT is the best option. Then the SLED, then the intermittent hemodialysis. Next one. So this is the machine which you have seen in our stall. This is the Kismax, the latest machine. Is designed for continuous renal replacement therapy, therapeutic plasma exchange, and even we can do for extracorporeal CO2 removal also. Recently we have done for a patient with a PCO2 of 140 or something. The patient was deeply comatose. Next slide. So this yesterday machine was being set up with a machine. This is just yesterday's photo. The next slide. Video. No audio. There is only this. No, I think there are some technical. Actually, I wanted to show how the connections are there with the video. That's a. Okay, go to the next slide. So this again the color we have in this CRRT what we do is we have 4 if you can notice in the machine we have 4 pumps. One is for the blood pump, one is for the replacement fluid, one is the replacement fluid whether we give pre-pump or post-pump, pre-filter or post-filter, and one for the dialysate flow. So we need 4 connections here and 4 bags will be hanging down. The next slide. So again the modes of CRRT, the common modes is CVV HDF, continuous veno-venous hemodiafiltration. It combines a pressure gradient to generate ultrafiltration and countercurrent flow of dialysate to provide dialysis. Next slide. So again this is a picture module where like how colors were shown. We have red color for the blood in, blue color for the blood out, and then for the yellow color for the ultrafiltration, and then green color for the pressure we give so that there is good amount of clearance. Next slide. And with CRRT, the adequate dosage is also required. See, because the common prescription we give is 25 ml per kg body weight per hour. Suppose a patient is of 70 kg, we almost 14 and almost 1.5 liter of fluid runs through the body, through the extracorporeal circuit, goes into the body and again comes out. Per hour, almost 1.5 liter is being circulated. So, adequate dosage is required, and because of the interruptions in the CRRT, it causes under-treatment. And some of these interruptions because of the blood clot, because it has to run for 24 to 48 hours, we need to thoroughly anticoagulate the patient. And if patient is already in DAC or bleeding tendencies, again anticoagulation is a risk factor. So one approach is to deliberately prescribe a higher dose. Instead of 25 ml per kg body weight, we try to give 30 or 35 ml per kg body weight. So just as important of dose of RRT, we need to change the medications also, because half of the medications which we give, the antibiotics are removed by the dialysis, by the CRRT. So we need to give more dosages of the antibiotics. Next slide. So these are some of the filters which we use. We have all these filters, ST is for the standard, And ST60 is for the patients who are below 11 kg, below 30 and more than 11 kgs. And the ST100 and 150 are for more adult patients, more than 30 kilograms. And then we have this AN69 members. AN69 members, there is no hypersensitivity reaction with these type of filters. Now, because blood goes through these filters for 24 to 48 hours, there are hypersensitivity reactions can occur. So this AN69, there are very less chances of hypersensitivity and it's so biocompatible. And again, we have all these M100 and M150 filter. Auxiliary filters we can use for severe sepsis or severe inflammation, cysts, and we can combine it. And then for the TPE, we have the therapeutic plasma exchange, and for the pediatric patients, we can use the HF20. So we can use the same machine, only we can change the filter. Next slide. So this was saying about the extracorporeal CO2 removal. The bright red one is the CO2 filter. It first the blood from the patient goes into the CO2 filter and then the CO2 gets removed and it goes into the again AN69 membrane and then it goes back into the patient. So it's like mini EXPO. The next slide. So these again there are different types of varieties of hemodialysis, hemofiltration, hemodiafiltration. This combines both hemodialysis and hemodiafiltration. This can be used in patients on CKD, not on AKI. The next one. So these again for the toxins, parapet poisoning is very common here. So these are some of these filters which we use routinely. The next one. So this is a hemoperfusion circuit. Here there is no dialysis, there is only ultrafiltration. There is no ultrafiltration of fluid removal. It works on the principle of absorption. Next. So these are the pictures in our hospital. This one is from Sagar Hospital for the hemoperfusion which we were doing for a parapet case. This was yesterday afternoon picture. Next slide. That was during COVID. And these are again the range of filters given for bilirubin, hyperbilirubinemia. Like DS330 we have done for a patient with GM Kiran's patient. For bilirubin of 45, it came down to 20. And then the second session it came down to 8. Patient, we prevented patient going into hepatic encephalopathy. Next slide. So these are the dialysis units at Adarsh Hospital and this is at Chalmada. There is another department in Chalmada also. Next slide. This is at dialysis unit at Sagar Hospital. Next slide. So this was the green one is the older machine which is available at the corporate hospital here, but I don't think it's working. This is a newer machine, latest machine which is available at Adarsh Hospital. Next. Next. Thank you. Request to all to look at the machine in the stall. The machine is there. Actually, we thought we'll demonstrate here, but due to some logistic reason, we cannot get the machine here. So, shipping the machine again, sensor will become a problem. Thank you.
Thank you, sir. That's a great initiative we carried here. So I would like Dr. Krishna here to discuss further on the matter.
ఏమంటావు?
Thank you, sir. Thank you very much. It's a great product launch, CRRT. We are very much proud. Dr. Sandeep sir is a nephrologist of Karimnagar, like treating all the kidney related cases. Recently, I wanted to add one more point, sir. So regarding Paraquat have given a lot of inputs, and it's a huge success from all the doctors of Telangana who fought against paraquat, doctors against paraquat, HRDA, and the nephrologist forum. So they all joined hands and got paraquat recently banned from Telangana. And the crucial role of Dr. Sandeep Sethi sir is there in that, giving valuable inputs. Adding on to it, very much proud Adarsh Hospital bring a CRRT, one of its first of its kind in northern Telangana except from Hyderabad. So I wanted to add 2 questions regarding this. So what is the cost? What is the cost? How much you are charging for CRRT if there is an AKA hypotension, if it is really indicated? There is a lot of hospitals wanted to refer for CRRT to Hyderabad. So we are very proud we have CRRT machine here in Karimnagar. And what are the charges and what are the commercials you are taking, sir, so that our doctors will refer any kind of case that is there, if it is indicated, they can refer.
Thank you. For 24 hours, we can do it in 1.29, because if you compare the cost at Hyderabad, it will be around 2 to 2.5 lakh. The same cost we can be able to do it in half the cost compared to Hyderabad. And you know, the patient gets shifted to Hyderabad, even the ICU cost itself, if here it is around 15,000 per day max. If they go to Hyderabad, it will be 50,000. Apart from CRRT, they need to incur more costs even for the regular care, even for the antibiotics, for the doctor consultations. So if we see it in that point of view, we can provide it at for 24 hours, approximately around 1.2 to 1.5 lakh, because it depends upon the volume of the patient. Suppose if obese patient, we need to use more fluid, 30 ml per kg per hour, so almost of 2 liters per hour. So it comes in all closed bag. It's a closed loop.
Very well, sir. Thank you. That is basically that's a reasonable price, and we are from MEDIEDGE. We wish you all the best, and we are proud that our motto is that same. The medical excellences in Type 2 and Type 3 city, and we congratulate Adarsh Hospitals for being a role model that Adarsh Hospital gives services of CRRT here in Karimnagar. We are really proud of you, sir, and wish you all the best. Thank you very much.
Thank you.
Mike.
Our next panel would be Precision Redefined, the rise of robotics across surgical specialties. The surgeon's hands are extraordinary instruments, but what happens when those hands are guided or augmented by robots? Robotic is no longer experimental, it is precise, reproducible, transforming outcomes across specialties from neurology to oncology to cardiology and gastro and general and neurology also. So our next panel discussion, Precision Redefined Rise of Robotics across surgical specialties. And I would like to introduce the panelists and the moderator. The chairperson for this session was Dr. Jagdishwar Gautsa, but due to an emergency he could not arrive here on time. So he asked us to go ahead with the panel. I would like to invite Dr. Mahesh. He is a consultant surgical oncologist, laparoscopic and robotic surgeon from Mallareddy Cancer Hospitals with 10 years of experience in oncology and surgical field. And he is the founder of Vihan, home-based healthcare services. Next, I would like to call Dr. Sesh Mohan sir, consultant neurologist, lab, robotic and kidney transplant surgeon at KIMS, Kompally, Hyderabad. He is a fellow in European Board of Urology certification. I would like to next invite Dr. Raghu Teja, robotic laser and laparoscopic surgeon, gut health specialist, founder of Cosmovet Dogs Collab and consultant as Onos Robotics. Through media and public speaking, Dr. Raghu Teja shares awareness on gut health, strength, lifestyle disorders and public awareness. So next I would like to call Dr. Amlesh, CEO and MD of Neurish Enterprises, visionary neurosurgeon, researcher, entrepreneur and an alumnus of University of Hamburg and other international universities. He is the author of the book on neuroscience and has many publications. He has a patent on a neurosurgical device in segment of neurology and neuroscience. Next, I would like to call the moderator, Dr. Harish Dada. Dr. Harish is a senior surgical oncologist and robotic surgeon with 15 plus years of experience, currently working at Malaradi Cancer Hospital. He is also the co-founder of Cancer Conscious Clinic, specialized in hybrid surgeries and rare robotic surgery. I would like to hand over to Dr. Harish.
Good morning, everyone. So, we are having good panelists, Dr. Mahesh, Dr. Seshmo, Dr. Arthur and Dr. Amlesh. So, generally when we think of robotic surgery, it is more of urology or gastroenterology surgery. Same rules, even the suturing part, especially in case of pyeloplasty, when you do implantation, psoriasis, body all the procedures, with an laparoscope, we know how much we have to travel to do the case. But especially the robot, it makes our life easy. So definitely the outcome will be better, surgeon will be comfortable, and definitely it has a major role, especially urology concern. And as for A integration, at present it is okay, but with the advent of DV5, will affect definitely DV5 itself is integrated with the help of AA8, so definitely will have a major role in the future. The other day I was scrolling social media. I saw one of the video, actually one of the surgeons, I don't know, he's a doctor, I don't know. He was saying the first branch that is about to go into surgery because robots are going to operate. So what is your take on information?
Because a robot doesn't know when to operate, when not to operate, when to stop a surgery. And a robot doesn't know about the clinical biology. And intraoperative decisions, we may need to take many exercises, which is planned, which is against the way, which is against the well-planned step. Okay? So during those dilemma situations, the robot is not going to take any proper decision. And sometimes we may need to take the help of the radiologist, and we may need to take the help of pathologist. So robot is not going to perform all those things. So definitely, robot is not going to replace the surgery. But it can improve the outcomes of the surgery from a robotic surgery.
So I just want to say that most of the doctors who are non-surgeons ask me, is robot is going to operate? No, it's not actually the robot is going to operate, it's the surgeon is going to operate on the robot. Just like a tool. So Dr. Karteja, most surgeons in India still practice outside the metro surgery. So what do you think are the biggest barriers preventing robotic surgery from becoming mainstream in surgery? Cost, training, cost volume, or events?
So the biggest barrier here is one is cost, second is people are not ready yet. Because I have served in Nalgonda as a consultant laparoscopic surgeon. When we advise laparoscopic surgery, they used to say like, current operation is laparoscopic operation, even for tubectomy, just take 5 minutes or 10 minutes to procedure laparoscopic tubectomy, but they are misguided by some laparoscopy open surgery. So now coming to robotic thing, the main thing is people are not yet ready on. Second is cost. Definitely there is a high volume, center has to be high volume for robotics. If you take a robot and if it is just performing like laparoscopic cholecystectomy and hernias, so that will not serve the purpose. main barrier here is one is cost and people are not regulate, and third is training. People are not trained like surgeons. They are not trained properly in laparoscopy. Then how can they perform? It is not just about sitting and controlling the process. We need to be like completely involved in the process. We need to master the laparoscopy only, then can perform the robotics. So it all depends on training and cost. People need to be ready for it. That is what I think.
More departments are ready, definitely going to work out during calculated hospital policy. The thing is, there will be multi-department involvement, definitely make a difference. Dr. Anish, robotics in neurosurgery is currently most visible in stereotype brain support or the spinal stimulation. Looking ahead, do you foresee a future when robots actively assisting tumor resection? Because I said
yes, it can be done, but the problem here is like adoption. Adoption is still lacking, and along with that, nowadays they are having retro placement, having more from the spinal cord injuries and also diseases. So that's the reason that English navigation and everything theoretic is still in the second stage, but it can be done.
What do you think is the most feasible robotic procedure for neurosurgery in India?
Aneurysm and also elbow. Feasible.
So, do you advise stereotactic brain?
Yeah. But the only problem is high.
How often do you advise like telesurgery, the role of telesurgery? Because the new advent of Indian robotic systems, when they are promoting telesurgery more often. So, do you really think that is feasible for neurosurgery?
It's really feasible. The only thing is the connectivity and guidance. This is the second challenge where we try.
Dr. Mahesh, in Tier 2 and Tier 3 India, many patients will still struggle for timely cancer surgery itself. How do we ethically justify robotic oncology in such settings? And where do you think robotics genuinely changes outcomes enough to deserve adoption?
So, at present scenario, Tier 2 and Tier 3 cities won't require a robotic system because there are many facilities which is commonly available in Tier 1 cities and which those are available since many years. Those kind of facilities or services not available still in Tier 2, Tier 3 cities. So before going for robotic services, we have to establish a center with basic facilities, which is highly basic facilities in all departments. So what I think is in near future also, we may not require robotics in Tier 2 and Tier 3 cities. And moreover, the role of robot is limited to very few organs and very few diseases in surgical oncology. So before going ahead with robotic surgery in all kinds of we should establish a center with all kinds of basic facilities. Then we should think of advanced technologies.
Considering cost effectiveness, you really advise robot for thyroidectomies, neck dissection, there are superficial surgeries.
See, for superficial surgeries, except for cosmetic purposes, there is no actual valid indication for robotic surgeries, except for the cosmetic purposes. It's like spending more time and more money and spending more time with the more than that, we are not going to achieve anything for superficial surgeries.
So, where in oncology, do you really say robotic surgery is actually needed even for a Tier 2 population?
See, it is not about depending upon the city or the population or patient. It's all depending upon the surgery where you want to perform, like pelvic cavity or thoracic cavity. So these areas will be having highly vascular structures along with the neurovascular bodies. So preserving those kind of structures improve the functional outcomes after the surgery. For example, we are operating a rectal magnus. So we need to preserve those hypogastric plexus. So by using the robotic surgery and doing low rectal surgeries, we will be 100% sure that we will be able to see those hypogastric plexus and we will be able to preserve those. So these are going to improve the outcomes for the surgery. It doesn't depend upon the type 2, type 3 population. So we need to choose the robotic surgery indication precisely where it is actually indicated instead of going against like fancy surgeries or cosmetic surgeries.
Virajji, arguably better robotic intervention globally because most of the surgeries in India, robotic surgeries are under evolved. We all know that definitely radical prostatectomy has made a robotic program as such in the time of gasping period given that birth to the robotic procedure because you know at the time in the initial stages of robotic surgery and the robotic platform has scaled. At the time the number of cases was the main difficulty and cost was the main factor. So there were many less number of people who were adapting robotic surgery at that time. So radical prostate has genuine advantages because the prostate is a pelvic organ, it's deep inside the pelvis. So we need to, with open and laparoscopy, it was almost impossible in few cases. So the robo has made the life easy because we can easily go into the pelvis of the 3D magnification and the better suturing with precision, magnification and the introduced instruments, it made the life of the robotic surgeons easy. And because of the great work done by Walsh and Manimedan, the robotic prostatectomy has picked up instantly. So that's the reason that prostate can expand in other departments, not only urology, in other departments, so many because of prostatectomy. And especially there are even removing the prostate is not the main factor now because there are other indications are also possible. We can able to preserve the uroscopic bundles, urethra we can preserve, diabetic we can preserve the endocrine patient, continence we can preserve, erectile function we can preserve. All these are possible with the help of robotic technology. These are not possible with open or laparoscopy. So definitely it has benefits.
With laparoscopy, we are doing a lot much better thing. See, police especially will perform in half an hour definitely. People are choosing robotic because it is all it's kind of as it is not that important in such cases.
Rather than we are working with the OT, that with this time people might do robotic circumcision. Dr. Anish, given the substantial investment required for robotic platforms, which neurosurgical procedures will have enough evidence to justify the routine use, and where is the evidence still lacking?
Yeah, substantial investment is because the robotics was over 20 crores. And the investment is like effect and also more high infrastructure. The problem in India and other compared to global is like effect and OPEX, the open expenditure for the hospital, the India is not investing in the health. That's the problem. The robotic adoption is very, and the people are really not at content with the robotic surgery also. That's the reason we need to make them a kind of learning curve, which is really important for the doctor and also for the patient, so that they can really adopt what exactly the robotic can do. Otherwise, it's really currently.
So I want to ask this question to everyone. So, are we creating better surgeons with robots, or surgeons will become better with robots?
See, robot is not going to make a great surgeon. Ultimately, it's giving some sort of comfort to the surgeon, which is going to help you getting better outcomes from the surgery. So further, you should know basically how to operate a surgery and gold standard open procedures. You should know how to operate. Then only you will be able to perform a better robotic surgery. So robot is going to help a surgeon to perform surgery in a better way, but it is not going to make him great.
Any tool in the hands of the tool is always yes. So it's not the robot, the surgeon who finally does, and in fact, finally understands surgeon's skill. So the final conclusion part for my is every surgeon should have expertise in open procedures, laparoscopic skills, then adapting robotic will be easy. Without laparoscopy and open knowledge directly and working on the robotic, definitely not be sure because a machine can fail any time. It may be break any time. At that time, we need to know open skill laparoscopy to cover the situation. That is first.
Yeah, it's true actually. Yes, the robot is creating great surgeons as well because surgeon can operate from Karimnagar, they can operate US patient as well. That's the beauty of robotic. And the second thing is yes, unless we have open access, open surgery access, laparoscopic stimulation to the surgeon, he can't master because the tactile sensation is much more important and the tissue respect is much more important, the judgment is much more important, and the cognitive power of surgeon is much more important, which robot can't replace. Definitely, if the surgeons gain whichever the robot is more of the advances into it, there has to be a proper skill. And yes, robot will make a lot of difference in robotics because as we said, we can operate from anywhere and long hours of surgeries. One more important beauty of robotics is long hours of surgery. Surgeon he will be like sitting and in the ICU room, control room, can operate for long hours at one moment.
So yeah, so robotics might be they cannot replace 10,000 hours of user because it's really impossible to replace because we cannot even understand robots cannot. It's like a kind of machine learning where we just teach them and they just make all the procedures properly. But they cannot replace 10,000 hours of user. That is everything. So the second thing is about robotics like minimizing the surgery time. It's not about like do everything, but still it's in the they cannot replace it.
Yeah, that's the thing. It is actually the surgeon who is the final conclusion. Surgery is done by surgeon, not robot. Robot is just a tool, like any surgical instrument, we are using a robot as a tool. But with extra added features. Now the need for this one, it has static feedback and also aid integration.
Thank you. It was a wonderful discussion regarding robotics. I would like to invite Dr. Aishika sir to please come on the stage to felicitate with the moment. Thank you. Dr. Seshmohan. To Dr. Seshmohan. To Dr. Raghutejas. To Dr. Anmesh. To the moderator, Dr. Harris. Thank you so much, sir. Thank you so much. Everyone from group photo.
అందరూ ఎందుకు ముందుకు వెళ్తారు కొంచెం మీరు వెనక్కి రండి బ్రదర్ ప్లీజ్ ప్లీజ్
Thank you. It was very wonderful, insightful discussion regarding robotics, precision, control, and outcomes that speak for themselves. Robotics is rewriting the surgical rulebook. Thank you for the moderator and the wonderful panelists, and Dr. Rajshekar sir to have honored them. Our next panel is regarding rehabilitation reimagined, restoring function in the era of advanced care. A surgery may save a life, but rehab is what restores it. And yet, rehabilitation services remain one of the most underdeveloped areas of healthcare in Tier 2 and 3 cities in India. So this session reimagines what rehabilitation can look like with advanced technology, evidence-based protocols, and a patient-centered approach. So I would like to now invite all the panelists. Dr. Ajay Kumar sir, he is the HOD of Department of Rehab at KIMS with 17 years of expertise in neurophysio with a PhD in physio and international certification, and has contributed immensely to the field of rehab, bringing global standards to India. I would like to next invite Dr. Sunil, is a leading pediatric occupational therapist and certified ergonomist in Hyderabad with an extensive experience of 21 years in this field. He underwent several specialized international certifications, training, standardizing the approach in field of occupational therapy. The next panelist is Dr. Shashika, co-founder and chief clinical prosthetist and orthodontist of robotic, prosthetic and orthotic rehabilitation in Hyderabad. Served as the head prosthetist and orthodontist for National Center for Divyagyan and Pearl, NCTE, Government of India. I would like to next call Dr. Narendra sir, experienced anesthesiologist, HOD of anesthesia at Malaradi Narayana Hospitals, skilled and experienced in oncology, critical care and pain medicine. He is the founder of Srimitra Critical Care and Rehabilitation in Visakhapatnam. Next I would like to call Dr. Priyam, Unit Head, HCA Suvitas Rehab and Recovery Hospitals, Hyderabad and Kolkata branches. He holds an MBA in Healthcare Management and a Medical Law certification. I would like to next call Dr. Saujanya, founder and medical director of Relive Wellbeing Studio, expert of functional medicine, genomic wellness and rehabilitation. She holds ISB Advanced Management of Program in Healthcare and PG Diploma and Business Analytics from Indian School of Business. I would like to next call upon stage the moderator, Dr. Sarojini. She is an ortho and trauma specialist, physio and rehab specialist with an experience of 12+ years in this field. After establishing a physiotherapy unit, her founding skills were further showcased in her ability to launch a pediatric rehab group. She is an alumnus of the Indian School of Business, and I will hand over the stage to her. Thank you.
ఇంకొక చైర్ తక్కువ పడుతుంది.
Hi, good afternoon to all my panelists. As you mentioned, it's because the first and foremost things I would be mentioning about the multidisciplinary approach which we have taken, and along with that, the thing is that we are definitely reducing the overburden of the tertiary hospitals, and that too almost on a one-third cost of the things which is in the hospital they are expending. The majority, the gap which as I can identify is the awareness, then care continuum of the things, and also the acute or post-discharge emergency management aspect. Because for majority of the understanding still today with all these kind of awareness, multiple rehab centers, especially in the Tier 1 city, talking about Tier 2, Tier 3, still the awareness is very less, and that care continuum and able to manage the emergency at home is still not. So that is the biggest gap which I can identify for the current.
Dr. Ajay, you know, pioneered neurorehabilitation like Rohan did. So when neuroplasty has redefined what we once considered seeing of recovery, in your clinical experience, where you think we are still dramatically underestimating the brain's capacity, and what interventions are we not using aggressively enough?
Good afternoon, everyone. At the outset, I would like to thank all the organizing for calling me here and having me here this panel discussion. And for the previous question, the plastic brain. Brain is plastic, it was and it is and it is going to be. It is a physiological function of the brain to be plastic. Plastic is the flexibility of the brain to learn, relearn. The function is lost, again relearn. We all have underestimated that once there is an insult to the brain, it can only recover to a certain extent. When I joined my undergrad in 2001, 24 years back, we all had a notion that if there is any stroke to the brain, it can recover only 3 months and 4 months. That is how we were taught. But now the entire paradigm has changed. Now there is no definite line for the recovery. Once there is a damage to the brain, it can recover at any time, at any extent. The important aspect here is the movement. The movement is a tonic for the brain. But how you give the movement, how you design the movement, how much you give the movement, it is again the technical skill, the clinical skill. So we all have been underestimating the movement is everything. Movement is a stimulus, potent stimulus to the brain plasticity. So though it is a fundamental point, despite having various technology in our hands in the market, everything is going to facilitate the movement. Movement is everything. Thank you.
That's how the concept has evolved since 20 years back to now. Thank you. Dr. Sunil, so occupational therapy is the most patient-centered discipline in rehabilitation, no doubt about it. So it begins with asking what matters to the person and not presuming what's wrong with them. So in the multidisciplinary team where the medical model still dominates, how do you assess the primacy of function and meaning over clinical methods?
So day 1, day 2 also we enter the NICU and NICU. We used to give at least stimulation and at least positioning of the baby and NICU neonate, and slowly we used to work in PICU and slowly we used to work in parental also. So early intervention starts as early as possible, and whenever it starts early, the outcomes are we are seeing good outcomes. So occupational therapy is not competing with the medical professionals, but it is completing it, because we are focusing more on functional cases. We are not seeing any scores or a test. We are seeing more of individual participation in the area, home and environment. Occupational therapy it comes from the prevention and then early intervention and home goals, parental and community engagement. So we have a experience of the day-one shelters. The medical field, my suggestion is it is not competing with the medical model. It is basically
the robotic processes have moved from science fiction to clinical reality, but access still remains deeply unequal to parts of our nation. How are you working to close the gap between the cutting-edge technology can do and what the average patient in India can actually access and afford?
Good afternoon, everyone. I bow to the academic and all of you, and thanks to Dr. Sharma and the team that invited me here. Yeah, when we are covering, that's a good question for the payment of people who are needing prosthetic rehabilitation. So I will categorize it into three parts basically. So when we are talking about how to reach and about the cost. So first let's talk about the reach. So firstly, reach is like what we do normally. We need to first reach to the patient, to the family of the patient, to make them understand. So basically when we have a specific plan surgery or something, then the patient needs to rehabilitation. So first option is making educated to the patient and family. So once that part comes, and then we have a support system, we have a empathy group. So there we pass on the information about the available technologies, and whoever is particularly to everybody we can't keep all specific options what is available. So firstly, education of patient and family, that is what is important, and that's the awareness that first we have to reach to the people who are needing the disability mass. Then comes the hospital or doctor. So what happens here? These all options are not quite fitted to any category of patients. So particularly to when we think about the brain control processes or a robotic enrolled AI-based prosthetic leg or hand. So we need particularly also the surgical process starts before the surgery and ends up after the surgery. Then the prosthetic is a part of it. So when people that we need to discuss with the doctor to understand that what is the plan, what level of surgery they are planning, and what kind of features especially we need to put those kind of processes, what kind of length is needed, particularly to put those processes. Because when we think about or when we see that these all options are available, yes, what is available worldwide, we have available in India. But yes, only one thing we are lacking is probably that communication first the patient and family, and second is with the medical practitioner who does the surgery. So once we discuss of all these things, then it will be a realization of this particular candidate will be a proper case for me. This particular kind of prosthetic options. Now talking about the cost. Yes, when we think about any advanced options of guiding processes and all or orthopedic devices, it has its own cost. Now, what we particularly are doing here right now is like we get the processes abroad, like we have most of the implants come from Germany or US, but there are implants, certain parts of the processes which are not very costly and that can be used and prepared here in India. So we have Make in India project, we have started manufacturing certain small parts, just a connecting link between the socket and between the processes. There will be an adapter needed. So the adapter is basically not required that it should come from Germany. We can get it done over here. So when we think about that, we drastically reduce the cost. Because a particular carbon fiber adapter or a titanium plate that costs at least 70,000 from talk about getting imported from Germany or US. But when we do the same material here in manufacturing in India, we have many facilities available. I am personally connected with IIT Chennai, so they are also these options available. Then we see about down the line 5 years or 10 years back, which was coming better options, sensitized movement, some coming somewhere around 4-5 lakhs. Now 15 lakhs also we can give. So that is what we are looking at. That's what is really.
So before even talking about the affordability of the patient, we talk about the access of the patient. So whatever the discussion with the team or surgical team, doctor, engaging patient attendance or counseling them, this all are applicable and can be done in Tier 1 cities being done.
Yeah, so basically here.
But when we talk about last mile reach, it is not about Tier 3 right now, but if we talk about Tier 1 different other major cities, how are we, what do you think should be done to have the access to the every patient?
So very particularly we take an example of Telangana. I have quite a good number of doctors to go. I know they are practicing here. So what we do CMH. We make them understand what exactly, particularly this kind of options, how the patient condition we need and how it can be treated. So that is what we do. And we have good number of patients from these areas. We list them out. So that's what I was saying, that empathy groups we have. So in that, only the patients are not there. We have their family members also. So we introduce the things, we make them understand this is what is the design. Whoever wants to have a trial, they want to know what exactly is whether their kind of stuff is suitable for those options. We give a specific days, like we have one arthritis day, we have one disaster day. So on those days we make it available on cities or like cities like here, and we do the trial and we understand, we make them feel like how it looks like, how it feels. So that is how it's okay.
Dr. Narendra sir, being a critical care specialist who is in pain management and even owning the hospital which is into rehab, rehabilitation. So there is a growing body of evidence around post-intensive care syndrome. So the consideration of cognitive, psychological and physical deficits patient carry out of the ICU. How is your unit actively building rehabilitation thinking into the acute care phase itself?
Good afternoon. Thank you for being invited. Post-intensive care syndrome would not start after discharge. It starts when the patient gets admitted into the ICU. What we do in our unit is we start from the day one, rehabilitation services from the day one of our ICU admission. In some situations, we cannot avoid muscle relaxation because they are areas where we cannot avoid. So we try to minimize it. That ample sunlight to the eyes, so that the patient's sleep-wake cycle remains normal. And other things are there with physiotherapy from the day one, mobilization out of the bed if possible, or passive leg moving, hand moving, minimum sedation, everyday delirium scoring are there. We do that. And rehabilitation is a part of an ICU, not a separate thing, because if one day of immobility of a patient is cost to the patient, his health and everything. So we try to avoid it. So rehabilitation should be included in the ICU.
Yeah, I found myself a little odd in this group of all rehabilitation specialists. It is a fact, maybe, the complete other side of whatever we learn in medicine. When we learn medicine, we are
not odd in the group.
Or no.
You are preventive and we are
hospitalization and no hospitalization person. Yeah, thing is, we were all trained that once a diabetic, that a lifetime, it's only when a label is attached, we start working on their health. And there was no looking back. From those days, we have come a long way in understanding the bigger factors for everything. Okay. The fact is that everything takes time for us to figure out, standardize, make it measurable. Unfortunately, in preventive health, while there are measurable outcomes, we are not still recognizing it on the standardized platforms of WHO or American associations. Unless they approve, we won't approve what we do. Okay, so we are all talking the same. Sleep architecture, measurable. God is already concerned. Just spoke of. Thank you, sir. Very first ICU I will be seeing with sunlight. I'm saying premium most hospitals not having a window, having their BEPIP rooms in parking level. So thank you very much for that. So the cortisol becomes your sleep-based cycles, your mitochondrial level can be assessed, your range of motions, the functionality can be assessed. Just that we never thought these were very important. And we took it for granted, and once hospitalized, we started measuring. So the moment we start measuring these and making people aware, you can do this right at your place, at the comfort of your home. I think that will stop, make it look like a needy thing. Wellness is not an elite thing, it's I think all of us need it, and we are all spending our life and time on it. Just that we are not giving the parameters, we are not educating people on the parameters to measure for themselves. Just the way we did for diabetes or hypertension or other lifestyle. That's what I believe. And at PA, everything is data. Thanks to ISP, they really oriented us to data, which obviously eventually I went to ISP to know more about data. And there are so many modules, so much of medical out there, where every data point is, we can record it. It's not just a perceived questionnaire where we can do it. It is very clear, so much of new age medtech that's coming and helping us. We need to embrace it, understand it, and put it into practice. And that's what we've been doing at PA, not just physical or functional, physiological health is quantified, psychological health is quantified, and not just BMI. BMI is absolutely yeah, it is doable, we are doing it, and that's why we will sustain. From the moment they step in to the moment they step out, everything is data that they can see with their naked eyes, not perceive that they are doing it.
You talked about enumeration, sunlight exposure, and integrating into rehab ICUs right from day one. So, if you talk about sedation strategies or the enumeration and delirium prevention, which are now recognized as a rehabilitation tools in this side, how do you navigate the tension between what is clinically necessary for survival in the ICUs and what we know causes long-term functional harm to the patient?
Both are important because clinically first comes the patient in an ICU, he has to next comes that he has to go home walking without very less. Hello. So there are some situations where we cannot avoid sedation. Once mobilization, passive movements, everything, so that the stay hospital decreases, survival increases, long-term cognitive dysfunction decreases. happening. What we do in our settings, there is a need of a clinical scenario, think of an ARDS. We have to prone him, relax him, and sedate him because lungs are bad. But in 2 to 3 days, he will be on the recovery phase. Then we start decreasing the sedation, decreasing the muscle relaxation, starting one, then enters the physiotherapy and rehabilitation road immediately. It should not be delayed for a long. What I think.
Next question is to Dr. Ajay. Sir, what we're talking about ICUs, populations and all, so when this condition is stroke, TBS and spinal cord injuries, patient arriving with increasingly complex profiles to hospitals, how are you, going deep into our neuro rehabilitation, adding certain certifications to your base rehabilitation course or concept what you have studied? How are you implementing technology, whether it's brain-computer interfaces, virtual reality or exoskeleton, in your neuro rehab protocols at your organization, and what does the evidence actually tell us versus what is the hope or hype?
This is a good question, sir, because right now we have been seeing how the technology is popping up. It's mushrooming everywhere, and the entire world is looking towards India because our density. And if you look at the insult to the brain, insult can be from the stroke or from the trauma from external or from any tumors or any metabolic causes, irrespective of underlying cause anything, we say there is an insult to the brain, there is a brain damage. Brain damage at what extent and what location of the brain it matters a lot. Despite having various technologies with us, and how are you choosing them to a particular patient? If you have a brain interface, or if you have a robotics, if you have an exoskeleton, if you have a non-invasive brain stimulations. So it is, right now our departments are like a supermarket, the technology supermarket, we have everything, but it is ultimately our judgment, how we choose it, in what level. Undoubtedly, this technology is going to improve the outcome ultimately, but how are you looking at it? See, each and every hospital is going to provide it. It's only the type of cities are loaded with it. And what is the matter of like the type of cities? Not every hospital is able to afford all these technologies. And coming to the point, we cannot neglect the conventional therapies. And it doesn't mean that we are underestimating the technologies available. It's all about the manifestations. Manifestation is going to decide what technology to be used. But my summary to this question is, technology is really going to help, but it's all about our decision, what to use where.
Not only in Tier 2 or Tier 3, when we talk about Tier 1 city also, not every hospital is implementing this, whatever the rehab pattern we are talking about. Why do you think it's happening? Who are the decision makers in this?
Ultimately, the technology what is coming now, there is a lot of monopoly, and each and every technology is like a cost like a bomb. It's the cost effective. And when any corporate or any institution, when they buy an equipment, ultimately it is a cost recovery from the patient. Technology is available, but technology is not only one thing which is going to help the patient. It is ultimately going to get a better outcome in case it is available.
To counter this, to extend this view further, so while implementing technology into any organization, because you are sitting at the management level, what factor do you
it needs to be, the cost needs to be definitely, we need to care about, revive that cost, but definitely not at a cost of getting it higher to the patient, what I can say, individually that particular, as well mentioned, okay, that needs to be identified whether it is applicable or not. It cannot be a very generic that whoever is coming, it should be coming into that protocol of advanced technology and all. So it needs to be both the way, which should be patient-centric as well as the cost effectiveness of the things.
Since we are at that, how are you structuring your care models to actually support, train and develop the family unit as a clinical partner than an afterthought?
So here, from where I would start, as doctor mentioned, that rehab starts at the admission, right? So it should be starts at the admission and not at the discharge. And also, it should be the caregiver should be part of that treatment from the admission itself, not from the discharge. Because that time they will not be aware what to do. And here comes the very vital role of the transition care, where the entire systematic team to be trained to the caregiver, and they should be part of the each milestone which the patient has been achieving, or care plan has been made to achieve that milestone. And as well as multiple families might be known, and as Madam also said, there are scores for pain, there are scores for fall risk, there should be also scores for care burden of the caregivers, which we don't have currently. So hence what we need to do to engage them more into the treatment, part of the treatment, and explaining them that what is the future of that, so that they should be aligned with the thing. And definitely we also should create, and what we usually follow at Suvitas, that there should be a PDC which is a post-discharge care. Definitely that's a plan which we made almost a 7 to 10 days prior the discharge has been decided, and it may be starting from any kind of exercises at home. There might be some wound management required at home. There might be some medication. There might be some follow-up which needs to be curated. Along with that, also there should be the assessment of the emergency when to go for the thing, because it is not that as again I will emphasize on that, it's not when the patient is got discharged from the tertiary care hospital, it is the end, it is the beginning. So hence, according to that, for me and rather for every caregiver, they should be part of each step of the patient journey. Hence, then there will be the recovery and the rehabilitation for their illness.
So now the most burning portion is out of pocket for rehabilitation. So that means the patients are getting burned out when they finish all or they come to the point of rehabilitation. Are there any insurances that are addressing this and are covering this, and what do you think the steps should be taken or to improve more insurance coverages for the patients?
Actually, the thing is that if the policy makers and the insurers are not come into the picture, then it will remain as a luxury in Taiwan city only. That I can say, because it's not a thing that it's very easy on pocket. Definitely it's not easy, but definitely it is lesser than the tertiary care, and it should be more awareness, and definitely nowadays there are multiple insurance TPAs are in the picture, there those who are supporting the thing, and which sometimes it's also covered under the post-hospitalization care of that, they have the package included in post-hospitalization care also. So it depends on the insurance, it depends on the TPAs and also, but what I would recommend that definitely the national health schemes and national policies should also coming into this bigger picture, apart from this only stroke management or any surgery or any emergency or cardiac things they are covering, or any planned surgeries. But post that, where is they should be coming into the picture, because it's not only about the getting recovered or getting discharged. It is coming back to the functionality. It is coming back to the quality of life. Hence, that should be continued through the government schemes and multiple more policy makers in the real.
Next question would be to Mrs. Shashikant. So, beyond restoring physical function, how does your center address the physiological rehabilitation of patients adopting the prosthetic or advanced prosthetic devices?
Talking about the psychological support and that way. So, first of all, here is one thing we need to understand. When we address disability, we should experience disability. So what we do normally, I work with certain organizations. So because here in India we see prosthetic equipment or rehab process. Particularly we look more or less into the village. But what we have certain organizations where I have worked, and for 6 months we continue the program to understand. Obviously, in 6 months when they stay with the family, with different people, so they will understand exactly the challenge and how to address that. So, in that context, if we see, so what we understand is experience disability means suppose somebody is blind, and if I say that, that person must be having a lot of difficulties in walking, and I am able to see that. So, experience disabilities from the family member, if somebody will make them blind for 10 minutes, or we just put a blindfold and show the experience that. So what that person feels now, this person will be having that the family member must be having an experience, so this is what exactly it is. So that is starts with the psychological support. When we say it starts from the family. And if the person, the patient, the person who is a disabled person, if that person's family is not supporting, he will be into a psychological trauma. So, not only about the prosthetic point, we just counsel them to work properly and go ahead with. But that should start from the family. First, then comes to the decision maker. Like, that's why when we do a plant surgery, we need to understand, we should make the patient understand that this is what is going to happen, and we should make them understand these are the challenges probably may come, and these are the advantages also. So you don't understand these things, then we will be going to the surgeon, then we will decide about the level of amputation. So people will be having quite a lot of patients in their mind, if they will cut my whole leg and what will happen, how I will walk. So that also puts the person into some kind of psychological trauma. So that we make them understand which stage of the competition and what are the benefits out of it and why we are going for that and what is the outcome. So that they can catch up that trauma in their mind. This is what is needed and we have to go. And with this level, I can do all such activities, whatever is available. Now, the last point over here is when again and again there will be a repeat cost to the process, because it will be just like a device. Like you are going for a car, after 5 years or 7 years, you need another one. So, when this option comes, in Western countries it comes under the insurance. But here in India there are 2 or 3 insurance companies which are covering. But what we do particularly over here, we suggest them because the financial burden also will make the person into a psychosomatic trauma to some extent. So, whenever they take the processes, we tell them like it's a kind of an investment. You keep certain amount for that kind of processes monthly wise, so that whenever you have a bigger need, like you have a changes in your head, body, the stomach changes, or like the joint flow or something, so there will be a cost which will
start with the clinical things that what I would recommend that this term rehabilitation and recovery should be included in the curriculum from MBBS and even in the nursing as well. Because after that, and when I used to be a clinician, when I used to discharge a patient, and it is maybe 14 years back, I used to write.
These things keep changing based on the government policy. But what is strongly important is the training at the school level, the university level, the curricular level, and the training at most important from my viewpoint.
As a pediatric background, I would recommend saying at the school level education in the area. Even national policy also, rehabilitation should include in all education level, not just only to the every education they should know the rehabilitation. As a pediatric background, early intervention, early identification, that gives very good opportunity to develop awareness, because most of the people don't know about the rehabilitation. After they get some problem, they know the occupational therapist, they know the physical therapist, but we need to educate public awareness and policy making, both these.
Here, we all are talking about the rehabilitation part, how it comes and what is exactly the treatment protocol, what should be in the policy. But I have a strong point here to mention when particularly we talk about Tier 2, Tier 3 cities or even Tier 1 cities also. Let's understand why the government is not particularly very much keen into the policies, taking into the rehabilitation into the policies or the people, the insurance people point about talking. The one thing, I was a member for census 2011, disability and census. This time also we are helping on that part. So, what is happening? The problem lies with us. When the census person goes to the a family and they find out about, because there are two type 1, first and 2. So first is about your building structures, second is about the population. So in the population, the number 9 is purely about the disability. In 2011, it was about grossly any categories, but this time it is about the 21 categories of disability. They have identified in a better way, and probably this census is one of the best one, because the digitalization and all is there. And now this time they have also made it on digitalization. Somebody is not interested to give the information, you can log in and you can give guide. So why I am talking is, we still feel a stigma telling about the disability of somebody in family to the people. So if we don't present the number properly, how government will understand? One thing I will tell, before 2011, the buildings, the government buildings, or even any private buildings, how many buildings are having ramps? After 2011, now we find there are ramps, because we made a mass scale understanding to people to present, you have disability, please stay, please inform. So government will understand that mass will be that in numbers. So when it will be in numbers, it will be easy for going into policies. So each one sitting over here, I should rather say that please pass on the message that whatever, if somebody in the family, somebody is having any kind of disability, that is all available in the website. So all 21 categories, any category, whatever, even you can understand the category, just say somebody is having some issue with disability. So let the number to come out. So once the number comes, then definitely the policies and all will be easy, and that mass can be presented in a better way. And regarding the policies, yes, there are 2 delegations already been last year happened. So probably I hope so if the same government continues in the next 4-5 years, it will be included. And but yes, as into the leading areas that we all know, we should also find out with all we should send out area we can represent our rights to our local person who are the police members, so that it can be assessed in a good way. Thank you.
All of us know everything, but everything is important. What they are told, everything is important. What I think is every nursing care hospital or which have an issue more than their colleagues, they can improve the rehabilitation centers or not some beds for the rehabilitation. Simple, every nursing hospital, Tier 1, 2, 3, anywhere does not cost anything. When you are setting up an ICU, it will be less than that. Cost will be less than that. I think there will be
Improving
a
accessibility and
accessibility will be easy because if you are having more than 10 beds on ICU and not 5 beds per rehab or a little space, what the space needed is, I think 600 square feet will be enough for a simple rehab for an ICU. Basic in a tier 2 or tier 3 cities.
Maybe I will sound practical, okay? The whole world runs around incentivization. As of now, the whole sick care, which we call healthcare system, is revolving around incentivizing the reduction in DALI, the disability adjusted life years, and not the quality. And all the rehab system is completely about improving the quality of life, not just survival. So we get paid for a surgery, for doing the surgery, not the outcome of surgery, and then effect on the outcome of surgery, not the quality of life of the person post surgery. The day this incentivization model moves towards reducing the quality, everything follows irrespective of the tier of city that we are in. Education follows, policy making follows accordingly, and then I think the awareness towards quality started because very recently, but the last year I have attended a summit where everyone was talking more about quality than DALI, and hopefully in a decade we get there because it's not easy, but we'll definitely get there. I'm very hopeful about it. That's when the standardization happens. All of us have been trying to get the same output in multiple different ways. We'll get standardized and everything else follows.
Thank you, ma'am. As we conclude today's panel, the message stands out clearly. Rehabilitation is not just about recovery, it's about restoring independence, dignity, and quality of life. So, the future of rehab lies in collaboration of clinicians, technology researchers, healthcare leaders, and policymakers to ensure advanced care be accessible, affordable, and patient-centric. Thank you, panel, for a wonderful discussion. I request the organizing committee to dismiss our panelists.
Thank you. Thank you very much for your valuable insights, and thank you very much. You came all the way from different places of Telangana to attend MEDIEDGE. We sincerely heartfelt thanks from our MEDIEDGE. I would like to call upon the stage to CARESUMMIT to felicitate the speakers.
All of you ready? Please repeat here. Yes, ready?
I would like to invite Dr. Sonia to give memento to Saroja. Thank you, Dr. Saroja, for the enlightenment session. Thank you very much. And now we go to startup showcases. We have 3 startup showcases. One is at your home, next CosmoGuard. After that, wipe your app. Please be ready. The startup showcase is for 10 minutes. So you are in 10 minutes you have to finish. So we have 3 startup showcases. One is at home by Harish and CosmoGuard by Dr. Raghu. Wipe your app by a CPS surgeon. Please restrict your time to 10 minutes. So we are moving on time. Next panel will be starts by 3 o'clock. Thank you. I hand over to conduct the startup showcase to Dr. Sai.
Good afternoon. Welcome to MEDIEDGE 2026 Edition 1. And coming to the startup showcase, now I would like to welcome Dr. Harish on his dais, please. Dr. Harish, who is MBBS from Usmania Medical College, MD in Anesthesiology, Fellowship in Liver Transplant. He has been involved in 500 plus liver transplants and 300 plus kidney transplants. Now he serves as head of liver transplant anesthesia and ICU at EXPO hospitals. Today he is here to talk about his startup at your home. At your home is a healthcare service which is patient-centered healthcare initiative focused on delivering quality medical care, rehabilitation, nursing support and medical care services provided to the patients in comfort of their homes. Dr. Harish, please go ahead.
Good afternoon, everyone. Thank you, Dr. Rajkumar, Dr. Sailai, Dr. Lakshmi Priyana, and Dr. Yasina for inviting me here and to the first ever Type 2 and Type 3 city, the largest health expo at Karimnagar. So I am Dr. Harish Sarvapla, and I am basically a liver transplant anesthesiologist with over 10 years of experience, and I'm managing the liver transplant program at States Hospitals Banjara now. So we did till now overall for last over 10 years we have done around 500 liver transplants, and we are successfully running the program. The thing is, but till now the transplants come under a quaternary care, which is happening only in metro cities like Hyderabad and Bangalore and Mumbai. The thing is, with the emerging diseases that are happening in the worldwide and increasing liver conditions and liver diseases and all, so we are planning to have liver transplant surgeries in Type 2 and Type 3 cities also, where the things are more accessible and more easier to conduct in setups like Karimnagar, Warangal and nearby areas also. Main focus is to shift the transplant center programs not only in cities but to the accessible to the Karimnagar and Warangal and Type 2 and Type 3 cities, which is our main motto to improve the quality of life and care in Type 2 cities also. Coming to my startup, which I have started, that is at your home. It is like hospitals saves life, but the complete recovery happens only at home. Because after transplant, what I observe most commonly is most patients, once they discharge from the hospitals, they will not have good quality of life at home, so that they will fall ill and sick again and again, which for this they have to visit the hospital again and again. So I found that gap, that is which is missing the quality health home care. So we founded at your home, the startup which is soon we are going to, in the next month we are going to launch the service where the continuity of the care will be delivered to the home so that the patients will not be lost, and the continuity of the monitoring to the surgeon or to the doctors at hospitals will also be continued throughout the journey of the patient, even at home also. This at your home not only focuses only on the home healthcare services but also a continuous monitoring system where the patient and the doctor will be in a loop of ecosystem where they cannot lose any track of the patient health status at any point of time. Here with the at your home, what thing is we have designed a website and app where the dashboard contains both patient's app and doctor's app, so that they'll have an easy monitoring of the continuous. And in our healthcare app, we have separate process for nursing, physiotherapy, and also any home-based respiratory therapy services also, so that the patients, whenever any doctor prescribes any care at home, any injections or any sugar monitoring, TB monitoring, or recovery happens. Ultimately, it is the home where the recovery happens, so that this ecosystem should not be disturbed by any other modalities, so that the doctor can hold the same patient and can treat the patient according to his vital signs, according to his medications and all, any changes in medications also. So here we use our nursing experts and also our respiratory therapists, everyone will be in our room, so that they can they'll go to the doctor, patient's home, and whatever is best to the patient will be done, so that the continuity will not be missing. That is the main motto and vision behind starting this project, because in the starting days we used to lose some patients because they are not following proper orders. Surgeon or doctor who gave instructions while discharging the patient. Due to some miscommunications, that proper things were not happening, so we have lost a lot of patients. That's why to bridge the gap between hospital and home, we started this home called At Your Home. That is, at your home, we get critical care services, home-based, like example, home-based healthcare services only. So me and Dr. Nikhil, we call him the neurosurgeon, and me, I am an neurotransfer service. So we both started this startup in the last year. And now we are going to launch often this program for the next month, June 1st, so that this Tier 2 and Tier 3 cities also can have this beautifully designed program, and later they can use it and they can tell us definitely how it is going to happen. I hope this At Your Home project will definitely get what the doctors demand and the patients need. And one more thing, what we are mainly targeting at this At Your Home project is like cost effectiveness by reducing the patient, by reducing the burden on patients' health, at the same wealth and health and wealth, because health is also wealth, right? So health and wealth at the same time, reduce the infection rate by reduction in the number of hospital visits, and also better patient comfort for the regular post-operative and rehabilitative services. So this is what we are mainly targeting, and I hope once the Tier 2 cities start the transplant programs like liver and kidney, definitely this one is going to help the Tier 2 cities, because every liver transplant, the patient comes to Hyderabad, the patient has to come, because in the transport only most of the patients are gone, because they have to stay in Hyderabad, otherwise So the thing is to reduce that, we are planning the transplant programs in Tier 2 cities. And first I want to start with the platelet donations. Like we have to create awareness among neuro hospitals, neurosurgeons, so that no need to ship the patient to other places. You can have it at the comfort of your hospital and we'll do it. So to that, to bring that transplant program and also at your home, we are planning to come. And thank you Rajkumar and Sai for this opportunity. Thank you so much. I hope it will be launched soon. Thank you.
Now, I request Dr. Rajkumar, you can state Dr. Harish Kilometer. Dr. Harish, we appreciate your valuable insights at MEDIEDGE 2026.
Yes.
And with the series of startup showcases, MEDIEDGE 2026, now I would like to call upon Dr. Raghuteja. Dr. Raghuteja, laser laparoscopic and robotic surgeon, is founder of Postmodern and is founder of Talks Collab. Postmodern is a platform dedicated to gut health, lifestyle transformation, liver health, proctology and preventive wellness awareness. And he also founded Talks Collab, a growing doctor-serving professional community which should connect, collaborate and empower healthcare professionals across India. Beyond healthcare, Dr. Raghuteja is a healthcare content creator with over 3 lakh followers on Instagram. Dr. Raghuteja, the stage is all yours.
Thanks a lot, sir. First of all, I'd like to thank Dr. Rajkumar sir, Dr. Kaishi and MEDIEDGE organizing team for a wonderful opportunity. Encouraging startups like us and young generation like us. Thank you so much. We doctors are competitive now. We are under a competitive umbrella. But it's a large, huge time that we need to shift our mode from competitive mode to collaborating mode. So this type of organizations or MEDIEDGE community is definitely helping collaborating and transforming ourselves. Coming to the startup showcase, my brand name is Cosmo Gut. Cosmo is cosmos, that is universe, and gut is our digestive system or gut health. That is, we must align with our gut. So people live with stars, they are under they see the universe for their future, but it is all dependent on our gut. That is what we deal with. Gut issues, gallbladder, fatty liver, and laser proctologist. So we doctors, coming to the doctors itself, we are like heavily occupied with our work, night shifts, especially junior doctors, healthcare professionals like nursing staff, even doctors as well. So all that is creating a lot of stress, which indirectly affecting our gut health. So people think that the gut health is a fancy word. No, it is much more important, and science is proving that. Based on that, we have started this gut health program. It's a 3 months gut reset program. In 90 days, we will reset the gut health system, digestive system. People who are suffering with acidity, GERD, bloating. We will be the solution. So health doesn't break down overnight. It will not happen overnight. So chronic stress is affecting gut health. Waking up time, these are the symptoms: chronic inflammation, anxiety and mood swings, bloating and gut issues. People are caffeine dependent, mainly corporate sector. Their brain fog, exhausted due to stress and work hours. So silently it is damaging our gut. Inflammation is rising, bacteria is very reason why. So we focus mainly to treat symptoms. It is having acidity or describing EXPO. There are different types of medicine, different types of brands. Yes, we are doing that. Anti-acid therapy for constipation, syrup, the actual dose. People are addicted to that syrups, and it is a bloating relief, symptomatic relief. But are we focusing on root cause? This is much more important to focus on root cause, like bacterial access, regulation, there is mucosal inflammation. Are we addressing that inflammation? HPA access, activation, cortisol, gut microbiome disrupts. Are we at least asking these questions or addressing these questions? Mostly no. So we can treat one symptom or two symptoms, but we are not addressing the cycle. This endless cycle, like poor sleep, high stress, inflammation, bacterial damage, cravings or increasing processed food, all this leading to lifestyle issues, metabolic overload, mainly insulin resistance, and this metabolic overload is the main issue which is causing diabetes, or you name it, PCOD, fatty liver. All these are based on one main important thing, that is inflammation, insulin resistance, and metabolism disruption. So your body is sending signals like heavy after every meal, sugar cravings, brain fog, mood swings. People are suffering with this. A lot of people with such type of symptoms, but we are not addressing them. We are just prescribing medicines. Root cause addressing is not, we are not focused on. So these symptoms are important, that they are giving signals that your body is giving you signal that there is something wrong with your body. We need to focus on that. So temporary relief like medicine, symptoms are reduced. Okay, you will feel better for a while, symptoms return, but healing happens only when the repair of gut lining happens, inflammation reduces, the sleep quality improves, the nervous system calms down, and the lifestyle imbalance. This all leads to transformation. This transformation will help in healing, not a temporary relief. So what we do is a step-by-step approach. First phase, remove. Second phase, repair. Third phase is rebuild. So we remove the toxins or diet which is creating inflammation from a particular client, or which is, then we repair. By repairing that lining, improve deep sleep. Then we help calm their nervous system by explaining the vagal tone exercises. Then we will rebuild the sustainable energy, balanced lifestyle, and we strengthen the immunity. This leads to long-term transformation. This will happen in 3 months. So people in this program don't just feel lighter, they feel alive, they feel alive. So energy will improve, sleep will be deep, emotional balance will happen, mental clarity, health will improve, which all results in sustainable results, long-term and long-lasting results. So start healing from inside out. This is our 3 months battery set program where we get gut repair protocol, summarize the client-based protocols, sleep and stress recovery system, which was guided by not a nutritionist or dietitian, myself and Dr. Teja, and laser and laparoscopic surgeon, robotic surgeon, treated almost 2,000 plus laparoscopic surgeries we have done. So what I have observed is people are suffering, students are suffering with IBS and all. So for them we have started this program. So we have a colon hydrotherapy sessions also. So I'm the founder of this postulator. It is based in Srinagar, Bangalore, Banjara Hills, and Hyderabad. This is colon hydrotherapy. The east side in Srinagar, we have this system of hydrotherapy sessions we do. But we are doing some campaigning through that mission. And post session we will advise probiotics as well and postbiotics as well. So this is the advanced mission we are having.
exactly at what time he will come. So a lot of time is wasted for the patient in all this available for the patient, I built a platform named Your Video, and it is live in Nizamabad now. And coming to the doctor's side, there are many pain points for the doctors also. Actually, the doctors need to more concentrate on the patients for their medical needs. But as an OPD doctor, we have many other non-medical things which we have to concentrate upon, like our marketing, our administration, appointment systems, follow-ups. There are so many things to do. Generally, the doctors are using different software for different things. Like for booking the appointment, they are giving their appointments on their website. And for the EMR and the digital prescriptions, they are using some other platform. For the billing of their consultations or labs or pharmacy, they are doing some other, taking some other subscriptions for the different other platforms. So instead of the doctor going to so many people, I thought it would be better if he gets all these things in a single platform. So we have built this platform for the doctor. We give a web page on his name, so the patient can discover them and book the appointments. After coming to the OPD, we have a queue management system where the patients we have reminders for every pre-completed patients. They will get a reminder like your token number is 50 and there are 14 people waiting before you, and this is your average waiting time. So depending upon the time, if the patient has some other work, they will do the work and come on time, and there is no need for them to waste the time in this. Next is the doctor can store all the data with digital prescriptions, upload images if you want any like pre and post procedural images, and keep all the data for the patients he has seen. Next is the follow-up, which is very much fragmented. Generally, as a doctor, all the doctors mostly concentrate on getting new patients. But what about retaining our old patients? When there is a good follow-up system, we can retain our old patients. And this system presently is mostly dependent on the staff who may work efficiently or not. So to remove this, we have developed a good follow-up system where the doctor, after the if he just types the follow-up day, automatically reminder we got the patient 2 days before that you have an appointment with so and so doctor on this date, you can book your appointment. So when we start reminding the patient that you have an appointment, there is a chance that the follow-up patients come back to the doctor's more. This we are starting, and then the home care services and the ambulance services also can be utilized by the patient. So as a doctor who has seen pain points of the doctor from the doctor's side, I have built this platform so that all the non-medical needs of the doctor are fulfilled on a single platform, and we are bridging the patient platform and the doctor platform so that the healthcare is streamlined. And we are mainly concentrating in Tier 2 and Tier 3 cities. This is not just an idea. We have already started it in Nizamabad, in January, and in last 3 months, we have almost onboarded 200 plus doctors, and we have a patient base of 7,000, and already the bookings are also started, and we want to go to each Tier 2 cities one by one. Most probably we will be coming to Karimnagar in 2 months, and we wanted to conquer Telangana Tier 2 and Tier 3 cities. So I hope I will get all your support, and thank you for the opportunity you have given.
Thank you, ma'am. Thank you very much for your startup showcase of Vaidu app. And I request Dr. Sai to hand over the memento to Madam. Thank you all that at home, Cosmogard and Vaidyo. We wish you all the best from MEDIEDGE team. Next, we move on to the next session of the panel discussion on expanding aesthetic care, bringing advanced dermatology behind metros. Dermatologist, Dr. Rajeshwari is the founder of Dr. Rajeshwari Skin Advanced Fellowships from various prestigious institutes. She is widely recognized for her expertise in cosmetic lasers and hair transplant. Here from Dr. Rajeshwari, ma'am, please. Next, the panelists. I would like to invite Dr. Raymond, a distinguished dermatologist with expertise in derma, hair transplant and aesthetics. He is the founder and consultant dermatologist at Ellora Skin and Plastic Surgery, a center focused on advanced dermatology and aesthetic and cosmetology in Colombo. The next panelist, I would like to invite Dr. Sujana, the plastic and cosmetic surgeon specializing in reconstructive and aesthetic surgery with expertise in body contouring, facial rejuvenation and cosmetic procedures. The gold medalist in plastic surgery from Osmania Medical College, known for her precision and patient-centric approach. Co-founder of Ellora Skin and Plastic Surgery. We welcome you, ma'am. The next panel is Dr. Deepthi. Dr. C.H. Deepthi Prasad is a distinguished dermatologist from Deepthi Hospital in Karimnagar. With extensive contribution to clinical dermatology and academic research, author of multiple publications and book chapters, recipient of several awards including Global Education Award, and we are proud, ma'am, that Dr. Deepthi ma'am is from Karimnagar. Ma'am is very active in social media and is educating all. And she is against the faculty where Karimnagar she is fighting against the faculty of cosmetology and dermatology. We welcome you, ma'am. And next I would like to welcome Dr. Sai Krishna, a dynamic dermatologist with young dermatologists, experience in clinical dermatology, aesthetics and academic presentations. He holds a special interest in biologics for psoriasis and atopic dermatitis and medical management of vitiligo and chronic dermatitis. He is very good friend of mine. He is my junior and is very much active. And he completed his fellowship in dermopathology in All India Institute of Medical Sciences, Delhi. Next, I would like to invite Dr. Sandeep. He is a plastic surgeon and reconstructive surgeon and experience in aesthetic surgery, contouring, facial rejuvenation, cosmetic procedures, and plastic reconstruction. He is known for his precision and facial-centric approach. We welcome you, sir, Dr. San. Now, I would like to invite Dr. Rajeshwari Madam to moderate this session.
So good evening all of you, and first of all I would like to thank to Dr. Rajkumar and entire team of MEDIEDGEHEALTH Summit, and along with my friends and all the plastic surgeons and dermatologists, Dr. Sujina Garu and Dr. Veman, Dr. Deepthi and Dr. Sai Krishna and Dr. Sandeep. So all of you very good evening and congratulations. So Dr. Veman, this question for you. Are you ready? So Dr. Veman, if you have chosen a plan to practice DNA metro, and which most of these you would not consider, and what were the biggest structural gaps you encountered on day one in infrastructure, or supply chains, or patient mindset, and how did you work around them?
Just like just and my education is from Visakhapatnam. Initially, I used to practice in Visakhapatnam. Just listen to it actually. So we are not of cost, and after state division, we have to move to our native place. Then a sudden shift in the practice. We have most of the clinical case and all. So cosmetology was never a part of my practice actually. So I thought of that. So my plastic surgeon. So infrastructure basically plays a major role, but apart from that, the major thing is patient awareness. Okay, so literally I have to educate people about the procedures, and especially cosmetology, all procedures are done in local parlors and all. So they never compare doctors for a cosmetic problem. So basically, literally I have to educate them. So later we have to move to cataract. So we have set up clinic, one of science center, clinic center. So the still I believe ethics, ethical practice, transparency, okay, and most we educate patients. We never push a patient for procedure and all. So that's how we have a clinic there. So patient are not very push that.
So yes, a Tier 2 and Tier 3 patients are in consulted basic dermatology and with the cosmetic parlor treatments. So nowadays, all the non-professional dermatologists like even paramedics also non-dermatologists, professionals and even the parlors, even the spa classes, there are a lot of treatments like dermatology, like the peels and anti-aging treatments, right? So this creating cluster division before the consultation, your brilliance, or have you built the clinical credibilities and educated the communities who have never had the access to specialists before? So what's your, we need to message to beyond the metro cities, people like the district levels and technical people. So how do you
generally for any cosmetic issue and other, they never compare doctors or plastic surgeons. So there is a confusion. So in this era of social media and all, so there are a lot of.
in case you are both are same, no? So plastic surgeon and
Yeah, so
how do you distribute the cases? We have the anti-aging cases, who will give?
particular females and I give it to that.
Place the focus.
Clinical
If it is any, then
because today something is mainly, so the clients are patients, they don't know that they need aesthetic or dermatology cases behind the pathological disorders. How they select what
selected subject list actually. What is the reality of the explain them. Then we give options to them. So then a present treatment or procedure actually. So we discuss more of long-term health benefits.
Now we must say doctor any because you know Dr. DK and Dr. Sarkishan and Dr. Sanjana, so almost chronic cases they are coming with us. After the treated in parlors, scars, like so many diseases and all those. So after the complication and minimum side effects, they are stubborn without result and all everything. Then only they are coming. No one patient primarily coming with us in district levels. So how to educate, how to, what will do all the dermatologists and practice and plastic surgeons? From your answer. With a lot of awareness we are doing, a lot of things. Yes, sir. Thank you so much, Dr. Yeah, mostly surgical treatments we discuss and surgical outreach camps. They have the long several constitutive needs like the cleptopilot and post-traumatic scars and post-accidental scars and post-burn scars. So in case you are extending this model toward the aesthetic procedures and how do you navigate the ethical questions of regarding cosmetic outcome in the resource-limited settings where basic reconstructive needs may still be unmet?
Good afternoon, ma'am. Thank you for the question. Whenever any patient comes to us, the main importance is the reconstructive benefit only. But at the same time, some cosmetic outcomes should also be, we have to think about it. Because, for example, it involves scars or reconstruction of the injury or disease. That will impact a lot on the patient psychologically and professionally. So, while reconstruction, we have to think about the cosmetic also, but the primary aim should be functional reconstruction. Ethics, definitely, most of our plastic surgeons, ethically, they treat mainly the reconstructive part only, but add on to that, we have to give aesthetically pleasing results without compromising any functional outcome.
Nice, doctor. Doctors, in case the people like mental headquarters, like district levels, what is the thing beyond the universities? So we are conducting based on your practice, we are conducting camps and regular cases. Whatever they the before priority advertising, what you are the procedure you are doing. In case of other than how they are reached to you, like you are in dermatology or plastic surgeon, how they are reached to clear palate surgeries and any reconstructive surgeries. What are the sources in our normal patients? How do you reach any platform? Because nowadays they don't know, because in the metro cities they know everybody. So what is the plastic surgery they do? What is the clear palate? What are the options are available in the procedures? And what about the district level people and very many people? How to reach the plastic surgeons?
People think of plastic surgeons only cosmetic surgeons, and they think plastic surgeons are not also. But we are here to reconstruct. Cleftically is not a cosmetic problem only, it is functional and later psychological disability. So we have to treat it. With coordination with the local district hospitals and healthcare workers in Tier 2 cities, then we coordinate with them. We'll put some camps, we'll get
communicate and awareness to practitioners and all. Thank you so much. Yeah. Thank you so much. And Dr. Deepthi.
అది వేసుకోవచ్చు ఏముంది కదా కరీంనగర్ కదా ఇది అన్నారు ఏమో మరి అది
Dr. Deepthi, nowadays in metropolitan cities like Hyderabad, Bombay, Bangalore, they know every client what are the facial resurfacing treatments, like the lasers, like high-flow, CO2 fractional lasers, the hair dye lasers, cellular lasers, right? And in case of beyond the metro cities, they don't know what is the high-flow, but they need it because they need the application and good looks and added skin and everything. So, question for you, high-end energy-based devices like QC lasers, high-flow fractional CO2, and when the required state operators seek to maintenance and infrastructure, which of these technologies do you believe are genuinely portable beyond the metro right now?
Yeah. The word is here. Basically, patients are very much aware. It's like they are trying to make the proportion is different. Type of the metros generally clinical as well as X-ray diagnostic. So people come to me, maybe it is not in very huge numbers, but they come to me for anti-aging treatments or anti-scar treatments. But as you said, if you want to talk about the machines, that much higher. These are little advanced anti-aging, but laser hair reduction, anti-scar rejuvenation, pigmentation laser, examiners, or whatever the basic lasers are there. These are very much used. It all depends upon how we portray. If people know that in practice, see, we might know many things, but people should know that these services are available with us. So there comes, I think, the importance of marketing. See, you might be knowing 100 technologies, but what is the point if people don't know that you do it? So I feel that it is type 1 or type 2. Definitely depends upon the doctor, the interest the doctor has. But for sure, there will be difference in the fraction of patients who come for specifically uterine treatments in metros as well as in type 1.
So basically, we need to awareness the people beyond the metro, right?
Yeah.
What is high-flow and what is CO2 fraction? Because out of 100, at least 15 to 20% patients they are running towards the metro cities. Even if Karnataka district level also you are maintaining high flow, they don't know. But in case of metro cities, the people they are asking directly, do you have the high flow? Do you have the CO2 fraction? And what is the company? You know, all the things. So marketing is very important. So regarding this.
Only marketing. Just tell people that what is happening.
Yeah. One more question, doctor.
Yeah.
So doctor, with the medical grade devices, and now they marketed directly non-dermatological practitioners, only the medical devices like hair tools, hair analysis, skin analysis like that. And even those salons also they are using the all those things tools, medical dermatology tools, right? So those patients, because we need patient safety is very important, right? What regulatory and professional guidance do you think that will urgently establish all the things?
Yeah. So this is a very big question with a lot of debate around it. We know that there are very strict rules formed by our government where who practices cosmetology, what is the definition of cosmetology, who is allowed to do cosmetic procedures, who is allowed to inject. So because of that, there is no regulations as such, because of which everyone wants to encroach into beauty field because this is easy, more elegant, more attractive and easy money. As a dermatologist, I feel two people are important for this. One, the core government, whoever is responsible, the bodies, the NMC bodies or like whoever is responsible, our dermatologist bodies, we should be able to regulate
strict guidelines. Such things, some problems will not be there in Western countries. There, who is a cosmetologist, who does a skin analysis, and who does a laser treatment, who does biological treatment. It's very much clear. Such things are not there with us, but we are very unfortunate for that. But I feel down the line, when we become more aware and spread the awareness, like who is supposed to treat which kind of diseases, probably down the line we should be able to form strict rules defining the roles of each profession. So once the rules are very clear, then everything becomes easy. And this one particular, everywhere I try to speak about it, anti-cracking. So it's something which each and every doctor, not only dermatologist, has the responsibility to spread the awareness about this particular topic, because people don't know. They just blindly come to you. You portray yourself on social media that you have treated so many cases and all those things. So what is the basis for it? There is no any proof of all those things until you go to the hospital and see. So we have a responsibility in controlling this particular category, and that responsibility lies with each and every professional. Even if you are responsible, without strict guidance, nothing can be done. So I wish and hope dermatology is out of category very soon. Not only dermatology, every other. When I talk to my colleagues, the doctors who are especially senior doctors, physicians, and surgeons, everywhere is the way.
Yeah, Dr. Deepti, we are studying the rules and everything we are following. There are so many non-practical dermatologies, like Silicon and Parlor and Smart people. They are earning a lot with all those things. That's what skills are getting. They are following, and they are getting a lot of clients, and they are leaders in the clinical dermatology. So, awareness is very important. We are always trying to have the people and other things, but their marketing levels is very different and higher than the dermatologists. So, we cannot do anything. So, we can always follow the rules and thank you so much, Dr. Deepti. And Dr. Sai Krishna. In between non-metro clients and patients and with professional doctors. So, do you think it can be primary the high quality modality of the aesthetic concern or inherited limitations? What do you think?
First of all, thank you for inviting me, Dr. Rajkumar sir, and giving me this opportunity. I am privileged to be here today. And thank you, Dr. Sai Krishna ma'am, for calling me here. I am junior most here. I am seniors. I don't know how to answer with the limited knowledge I have. I will try to
Yes, we are asking what is the teledermatology, how you work, and little bit basic knowledge in teledermatology in the metro cities, but how do you know in communal peoples like the peripheral medical people, vaginal people, they don't know telemedicine, and even how the communicating between patient clients, what is the sources, like anything primary healthcare to us, anything rules are there?
I will try to answer now. I will try to answer with one line point. AI will not replace the dermatologist, but the dermatologist who is using AI will replace the other dermatologist who is not using AI. So, any dermatologist is very much important, and it is helpful, but how much the data privacy is there? Because dermatology is more of images, more of before and after images, and now the protocol is that because before and after images, even we blur the eyes also, we are not ethical to keep the images in the WhatsApp or Instagram. To keep the before and after images also, we need to have the written consent for the patient. But that is not happening. That is yet to happen in the future. And there are many medical legal cases will be happening because of this AI, because of teledermatology. Because vitiligo can be diagnosed as cancers will be missed in the pigmented patches in teledermatology. If you see in the photographs, if they are not properly trained, and the training should be given very particularly by the dermatologist only to the primary care physician. How to take the photograph, that is very much important. This is a very much big topic in Ayurveda. How to take the photograph, we have a big class for that. It is not that just we take the photograph and send to the dermatologist, then we diagnose. Then the misdiagnosis will happen, and overdiagnosis and the underdiagnosis may happen, and there will be steroid usage also in that case. So what I feel is till now, the network issue, data privacy issue, and the images, they can't send the images. Just like to the dermatologist. area and all, we can guide the patient for the immediate treatment, and urticaria is a chronic disease. It is not like hydrocortisone or prednisone and all. No one can use the prednisone for long term for urticaria. It is misused now. It is autoimmune disease, immunological disease. It has to be properly taken by the dermatologist. This will not happen in this dermatology again. And what you think is dermatology is useful for acute cases, but for now we have to train the primary care physicians for the how much they have to take the photograph, which camera to use. The quantity care technique has come, but quantity care is how much cost? It is 3 lakh cost. But how much they can government can use the camera?
So that is why there is useful or no primarily. Because so many clinical dermatology, so many diseases are there. Like you said, whatever things. But whether this is useful or no.
Useful for acne, but not
acne. The only between communication rural people and the doctors, there is only the photographs only. They don't know how to do photographs, but some people photograph easy. So that very medicine, dermatology, finally it is useful or no?
It is very much useful. It is very much useful that there is nothing mistake in that because the Hyderabad level state should be available for dermatology. That will be available in dermatology. But how much the primary physicians can take the photograph and give the history, that is important. And the data privacy issues, that has to be taken care. In my knowledge, dermatology is useful for acute cases, for urticaria, for acne, superficial melasma, external melasma if we can just think of external melasma or dermal melasma. In those cases it's useful, but acne starts and off, we have to see the texture, we have to see the depth and type of scar, and the procedures we can manage. We can use the technology for counseling the patient. How much duration we can give the procedures, whether to go to the procedures or not. Sometimes just the counseling can help.
At least we can avoid the CR application because
yes.
They are going to RD practice.
Yes. That can be avoided by the
everyone is doing the CR treatment and everything. It is like saving the patient from their knowledge.
Yes.
So that practice primarily is useful for the dermatology, particularly rural and metro patients, right?
Yeah, that is true, but app should be very much good with no data breach issues. And the primary care physicians, as I have again said, primary care physicians should be particularly trained to take the photographs and to give the history to the dermatologist.
So there is a gap in between even though dermatology need to help with primary care doctors and their practitioners, everything. We integrate, we train them. Yes. So at least we can get the proper recognition.
Yes.
Right. Thank you so much, Dr. Sari. Thank you so much. Dr. Sandra. Everyone, the clients in the metro cities, they know what is the non-Indian procedure, non-Indian procedure. Everyone, even in Hyderabad and every cities, they are asking any non-operating procedures available, like fillers, botox, and fat burning injections, and any weight loss devices. But they don't know even the non-metro cities people, like beyond the metro people. They don't know what is this, all the things. And even though who will treat all these cases if they want, even though they need, either plastic surgeon or either dermatologist. So what's your comments?
I think it's better not to have a turf war and better collaborate between a dermatologist and a plastic surgeon in a collaborative network way. So dermatologists usually they deal with skin rejuvenation procedures, whereas a plastic surgeon basically structural facial procedures they do. So in non-metro cities, I think a multidisciplinary referral system that will build better patient trust rather than care for. That's what I think.
Okay, doctor. And one more question, doctor. If you have been exploring the hub and and the spoke and franchisee clinic models, but to scale aesthetic surgical care behind the metros. What have you learned out about those make these models financially viable and clinically safe? If you are practicing, it's very huge in metro cities, then you need to franchise the model in the district levels and behind the metros. So how do you feel when we get what you are expecting?
I think aesthetic healthcare.
Because Dr. Sandeep, you need to all the whatever the aesthetic and plastic surgical and dermatological surgical procedures, our non-medical people they also have to use. So how do you think about if you are branch open in the Karimnagar, in Jadidya, in the Mancherial?
Aesthetic healthcare, we can't open it like a retail business, but it should have low infrastructure costs and affordability should be maintained, and at the same time the outcome should be predictable, because if we explain more about complications, patient will obviously go to a higher center. So low invasive and better outcome procedures, if we target that, then that will be financially viable. That's my opinion.
Because so many upcoming dermatologists coming into the not only the cities, they wanted to practice in district levels also. So how they start and all those things, how they get the patients, these kind of like fillers, botox and chemical peels and all.
Yeah.
Can you suggest the upcoming dermatologists and plastic surgeons anything?
Usually, sometimes they will manage it like this. First, they will have consultation here. So, they will, if it is a minor invasive procedure, they will get it done at a peripheral clinic. Or if it's an invasive procedure, they will be referred to a hub center where they will get the main operative procedure, and again follow-up will be done at a peripheral clinic. So, in that way, patients will be managed properly. Because first patient will come, will consult, then they will get operated at a metro city. Then they will come here for follow-up and further minor invasive.
Yes, at least we can help the patients and the doctors also. And Sandeep is the last question. So many patients, they are following all the previous before the Instagram influencers, right? And now they are following even the AI influence also. Whether they don't know whether it is really or the AI, whether what is there, but they are following, they are running towards the non-dermatological practice and non-plastic surgeon practices. Those patients they are getting, finally they are losing the money, they are losing the time, they are losing all the skin texture and the loss of hair also. Those kind of psychological devoted patient clients, how do you means motivation and how do you help their mindset and all? If you come with you in practice, they lose all things, money, lose hair loss and skin texture loss, and they came to you finally. What they need the outcome finally, and they are into psychological default also.
Social media awareness is a good thing. It will have positive impact, but at the same time it will create unrealistic expectations. So I think first thing, rather than the procedure, the counseling part is more important. Both should have equal weightage, counseling and the procedure. So first we should speak with the patient whether they want the procedure or some external pressure is there, or whether they have if they have a realistic or unrealistic expectation, we should take. If they have unrealistic expectations, I think we should stop there and we should say no rather than going to the procedure, because post-procedure will have more issues rather than cancelling the procedure.
So let's start. So we need to what happened there previously in the treatment, what they did the fault and all that, we need to aware them. Then basically we need to start the basic things. Again, we cannot do the procedures and all those things. Again, they are fed up and all, they are more into psychological things. So thank you so much, all the
Thank you, madam. Thank you for that elaborative session in dermatology and cosmetology. The one thing, the department which is affected with the quackery, 50% above is the dermatology. Why? Because every social media influencer is becoming dermatologist. So they gain him as a cosmetologist, as a dermatologist. My point of question to all the plastic surgeons and dermatologists and qualified cosmetologists sitting here. So what are the steps should we combine to take on preventing the quackery in dermatology? As well as we don't have any stringent rules on social media. So social media, even NMC guidelines are not precisely given. So my question to all of you, so please give your suggestions each and everyone, how we combinedly, not only dermatology, but we combinedly as doctors should prevent quackery in cosmetology. Over to you, sir. Thank you.
Actually, nowadays we started showing the complications created by non-medical people, especially through Instagram. They are doing multiple procedures. So whenever they end up with a complication and they are attending our clinic, so we are recording it and we are telling to the public that this is a complication done by a non-medical people, so who doesn't have a proper training. So better to consult a board certified doctor rather than some non-medical.
Dr. Sai, what is your scenario in Varangal? So how combined, my question is how combined we can prevent the quackery in dermatology? Combined means as well as your association, as well as the associations like IMA, HRD, Thana and all. How we combinedly should fight to prevent quackery? In a place like Varangal is also tied to city, so how we can do that? Thank you, Dr. Sai. Dr. Deepthi ma'am is very much active in social media also. So how combinedly you take and preventive steps to prevent quackery?
Some specific bodies to be formed against anti-quackery, and we need experts
అనేది కాదు అనే భయం మనం క్రియేట్ చేయగలిగితే ఎవరు మనలో చేస్తారు. అండ్ సెకండ్ థింగ్, సోషల్ మీడియాలో దెర్ ఆర్ లాట్ ఆఫ్ ఇన్ఫ్లుయెన్సర్స్. అక్కడ ఎలా పరిస్థితి వచ్చిందని a person will create a profile and he or she will going on suggesting the skincare, dry skin, sensitive skin. Who's going to stop speaking all those things? There are no many things there. Instagram, social media. So after something to be able to hold. So who is that person? One profile check that. One name on the once again I'm saying it is very easy to speak, but practically there is a lot of steroid combination tea, which has a clobetasol, gentamicin, anti-fungal, all those things combination tea, market looks and build out these totally. When the government is not able to hold that sale of those products, how can you prevent common steroid damage? Actually, obviously there is a way change but the agreed protocol under the suggestions are not considered. It is very difficult and as being a part of
Thank you, Dr. Preeti. Impact. Thank you, sir. What is
recently one of our colleague plastic surgeons started campaigning in Instagram. She posted post-operative complications after just globule gumming procedure. Nowadays, gumming procedure for earlobe holes, that is very popular in beauty parlors. So they came to us with a large device after once to do that. Some acid they are using, I don't know. After that, about doctor and they are coming with the reconstruction. What reconstruction? Large device of the doctor. She started Instagram campaign. If patients will attract low pricing and they want the level. So, and cost should be very less. In Instagram generally, these dental surgeons, they are eligible for hair transplant. So, our national government should take action about this. Because as per their association is legal, as per dermatologist association is not. At least there will be some overlap between plastic surgeons and dermatologists. Even though I don't do any dermatologists, I do plastic surgeons. So, yeah, government should take some action. You have to take lead for that.
Before going to Dr. Rajeshwari ma'am, first of all, I wanted to extend heartfelt gratitude and thanks for conducting this marvelous session with your marvelous speech. And as a dermatologist, madam is a very much experienced dermatologist, runs a clinic on the name of Dr. Rajeshwari, clinics in Hyderabad as well as Karimnagar and other parts of the country like Chennai and Bangalore. She is extending a lot, and she is bringing up a state-of-art center in Hyderabad. And first of all, thank you very much, ma'am, coming all the way from that place and conducting this marvelous session. Thank you very much. So please give your opinion on the dermatology and quackery, how we can tackle it.
Thank you so much, first of all, Rajkumar, for this all, what is it called, about weekend and all. So thank you so much. And all my colleagues, dermatologists and plastic surgeons, what they are saying like that. First of all, the marketing part, the influencers. So first of all, we need to stop the influences, but we cannot stop only the plastic surgeon and dermatologists. We cannot stop the influences. So whatever is the marketing. The number two, what are the patients coming with us? We need to at least awareness for them. So can you please, if you have any problems like this and like that, you can go for the dermatologist, otherwise a plastic surgeon, but don't go so and so. At least from our side, the clinical practice we can awareness. The moreover, at the same time, we can take the support with media meetings. Because recently, I think 6 months back in the Hyderabad, so many clinics they are closed. The non-dermatology practice clinics they are closed because of media support. So the media people also, they know what is the right and what is the wrong treatment they are doing. Non-dermatological and non-plastic surgeon treatment. So because I think that time only the media people they help lot of, so they remove lot of close the clinics also. So finally, what I am saying, no. So whatever the doctor very sir told, no. So we need to try to awareness through association, whatever the availability, and at the same time IMA and at our clinic walk-in patients are our patients. This all the things is useful for dermatology and the plastic doctors. And the finally plastic surgeons and dermatology, the combined practice is very important, and that's very important. And Dr. Sujana said that dental, the people they are also dental doctors as a part of hair and skin for us. I think that case is still going on in the High Court or Supreme Court because the dental people they are telling hair and skin they are also practice, but the hair and skin is a part of only plastic surgeon and the dermatologist.
Thank you, ma'am. Thank you very much for this elaborate session. And I would like to request Dr. CARESUMMIT to come onto the stage and hand out the mementos. Dr. Rajeshwari. Dr. Sujana ma'am. Dr. Sadiq, Dr. Sai Krishna. Dr. Venkam sir. Dr. Preeti madam. And Dr. Sadiq sir. Thank you very much. Let's join for the group photo. Today's last topic for today's medical summit, I would like to invite Dr. G. Sai Jagan to give his valuable talk on ethics and awareness.
అది ఉన్నాయి రివ్యూలు ఉన్నాయి ప్రోడక్ట్ లాంచ్
बैटरी आओ बैटरी आओ మేము కొంచెం మైసూర్ బీచ్ కూడా ఫోటో పెట్టాను రుద్రది ఆఫ్టర్ రుద్ర
Before this and awareness program, I would like to invite Dr. Rajesh, Dr. Lifestyle Clinic, just bring about for 5 minutes.
Which damages the eyes, kidneys and the neuropathy will happen and can glucomas will happen because of the microvascular damage that is happening because of uncontrolled sugars. And macrovascular changes will lead to heart attack and paralysis, and non-healing ulcers, gangrene, amputations. Every year in India, 40,000 people are losing their food because of the uncontrolled sugars. When we reverse, we will be able to prevent all these complications. And another thing is dialysis, which is CKD. And when a patient has dialysis, then it is like reverse. I mean, there is no possibility of coming back again. I mean, it's a reversible phase. I mean, as we know, weekly 2-3 times patient will go on to dialysis, which is painful and financially expensive for the patient and family. So, silent on that. As I know, diabetic patients will not, a lot of patients will not feel the sensation of pain. So, in this way, diabetes will cause complications and damage organs. Multiple complications will happen with the diabetes. So, which leads to financial expenses as per Times of India. Average diabetic patient is spending 15 to 20 lakhs for all the complications that we have discussed, whether stenting, bypass, and paralysis or dialysis. When we reverse, we will be able to prevent all these complications and save the money. Apart from money, as per the Lancet study, diabetes is reducing the lifespan by 10 to 14 years. When we reverse, we will be able to save the money and increase the lifespan and improve the quality of life. Why quality of life? If patient is dying in the dialysis, he roam around the hospital 60 to 50 times, or the paralysis, he is repeated. It is not a quality life. So when we reverse, when we do the remission, we will be able to prevent complications and improve the quality of life. Yeah. So, a lot of people think that only medicines are sufficient for type 2 diabetes, but as per the Lancet study, apart from medications, along with the medications, we will do proper diet and lifestyle changes that will help for us to prevent complications and reduce of complications and improve the quality of life. So, in a similar way, hypertension will also lead to multiple complications like a stroke, vision loss, heart failure, heart attack, and kidney failure, and sexual dysfunction. So, a lot of people don't consider obesity as disease, but as per World Health Organization, obesity is also a disease and it is considered as mother of all lifestyle issues. Because when a person is obese, he will get this of multiple issues like diabetes, high blood pressure, dyslipidemia, and knee pains of osteoarthritis, and cervical and lumbar spondylitis, and fatty liver, and inferior PMOS. There are a lot of complications will happen with the obesity. When a person loses weight in a right way, with a proper diet and lifestyle changes, and a proper habit change, then that helps. Even 10% of body weight will help to reverse the multiple issues that happens with the obesity. That is the beauty of losing the weight in a right way, not with the fancy or the fat diets. Okay. So, if you see any other lifestyle issues, whether there is a diabetes, blood pressure, obesity, or fatty liver, all these things are linked with the lifestyle. If you see the underlying root causes, the 6 pillars that we have discussed: lack of proper diet, lack of exercise or the sedentary lifestyle, lack of proper sleep or the late sleep, stress, emotional issues, and alcohol, smoking. All these are the contributing factors. Where we are not focusing on this, when we focus on all these things, obviously we will be able to prevent and reverse the issues. Thank you, Lakshman sir, for giving the opportunity.
Thank you very much, Dr. Rajendra, for insight and lifestyle medicine. Next, I would like to invite Dr. G.S. Sharan Sai, co-option member of Telangana Medical Council, to deliver his talk on Code of Medical Ethics.
क्या थीम ఏమని ఏమని వై లేడీ డాక్టర్ ఏమని ఈ చూడు ప్లే అనుకో స్క్రీన్లో ప్లే చేయాలి చేయలేదు
ఉన్నా సార్ సార్
కాదు
Good evening, everyone. Respected colleagues and dear colleagues, I am going to present on board of the ethical regulations of Telangana Medical Council. That is adapting from the Telangana Medical Council. These regulations are based on National Medical Council. So the main aim of this presentation is how ethical principle ensure safe, responsible, and professional medical healthcare. So you should know the medical ethics, mainly professional conduct, responsibilities, communication, and ethical decision making. To helping in maintaining the patient trust, dignity of the profession, accountability, and quality health care. These are the 10 sections in the medical ethics in National Medical Council. Every doctor should be familiarized with these 10 sections and the subsections. Mainly, the character of the physician, maintaining a good medical practice, medical records, prescriptions, duties of the patients, doctors, consultation, physician to physician responsibilities, and the responsibility and the duty of the doctor towards the public, any unethical acts regarding the pharma industry influence and the professional misconduct, and in the case, disciplinary action. This is the importance oath. So the character of 1.1, the character of physician. A physician shall uphold the dignity and the honor of all of the medical profession at all the times. The primary object is to render service to the humanity. The financial reward is always a subordinate consideration. A physician must be upright in person, pure in character, diligent, modest, sober, patient, and should be proud. Only doctors with qualification implemented by the Medical Council of India, later National Medical Council, and Telangana State Medical Council may practice modern medicine. The core, maintaining a good medical practice. The many patient confidence should render the full measure of service and the devotion, continuously improving medical knowledge and the skills. Practice methods of healing form should be on scientific basis only. Responsibility extend not only to the individual but also the society. At least 30 hours of continuous medical evaluation should be present for the renewal every 5 years. So, maintenance of medical records. Indoor patient records must be maintained for the minimum of 3 years from the commencement of the treatment. Document must be issued within 72 hours upon request by the patient, attendant, or any legal authority. Maintaining a register of medical certificate with identification marks of the patient, signature, and thumb marks should be present of the patient. Efforts should be made to computerize medical records as early as possible for quick retrieval. So, what is display, registration numbers, and generators? Registration number must be displayed on clinic, chamber, and all the prescription certificates and any money receipts. The generic drug prescription. Every physician should prescribe drugs with capital names legibly, generic names legibly, and preferably in capital letters. Regional prescription and the use of the drugs must be ensured at all times. So quality, ethics, and the payment. Safeguard the profession against those deficient in moral character or education. Never employ unregistered attendants. A physician should expose without any fear or favor any incompetency, corrupt, dishonest, or unethical conduct. Announce fees before rendering services. No pure, no payment contracts are totally unethical, and do not enter any financial conflicts within the patient interests.
Physician must observe and comply with all the relevant acts, Drugs and Cosmetic Act, Narcotics Act, Medical Termination of the Pregnancy, Human Organ Transplantation Act, PNSDB Act, Mental Health, Environmental Protection, Drugs and the Biomedical Rules. So the duties of the physician to the patient, mainly the patient's secrecy, maintaining the confidentiality of the patient, proper prognosis and non-abandonment of the patient. So obligation to the sick. Respond to the calls of the sick and injured promptly. A physician may advise a patient to seek another specialist, but must treat the emergency. No physician shall arbitrarily refuse treatment to a patient. Medical practitioner within capacity detrimental to patient or non-permanent to practice. A physician must treat a patient in emergency. There are no exceptions. Secrecy, prognosis and non-neglect. Patient confidence must never be neglected unless required by the law. May breach only to protect others from the communicable disease. Neither exaggerate nor minimize the gravity of a patient condition. Patients, relatives and friends must have accurate knowledge about the patient health. Once a case is undertaken, a physician must not withdraw without adequate notice. Willful negligence depriving necessary care is professional misconduct. So, duties of physician in consultation. Consultation rules. Avoid unnecessary consultation. See consultation only in serious, doubtful or difficult conditions. Pathology or radiology consultation should be ordered judicially and not routinely. In every consultation, patient benefit should be the foremost thing. All physicians must be frank with patient and attendants. Utmost punctuality must be maintained for consultation. Statement to patients must be made in the presence of consulting physician. Every concept of differences to be explained impartially. Identify the physician may vary treatment of consultation. If unexpected changes occur, reasons must be discussed at the next consultation. So referring to the specialist, a case summary must be provided when referring a patient. The specialist must communicate their opinion in writing back to the attending physician. Fees and charges. Clear display fees on chamber boards and hospital display. Prescription must state if the physician dispenses medicine. Write full name, designation, registration particulars on prescription letter pad. In government hospitals, where maybe patient note is present, prescribing doctor's name must appear below the signature. So, responsibilities of the physician to each other. So, physician to physician responsibilities, mainly mutual dependency, consultation limits, appointment of substitute, and visiting another case. It is a pleasure and privilege to render gratuitous service to all the physicians and their immediately family dependents. No sincerity, rivalry, or envy. Respect the physician in charge. No discussion before the patient or relatives. Consultant must not take charge of the case, especially on sensitivity to the patient. Must not criticize the referring physician. A substitute physician must be in best interest of the absent physician and restore the patient's upon return. Official visiting physician must communicate with the attending physician first and avoid remark on their treatment. So duties of the public and paramedical professions. Public health and community duties. Disseminate advice on public health issues. Enforce laws of the community. Cooperate with authorities in administration of sanitary and public health. Notify public health authorities of every communicable disease. Enlighten the public on quarantine measures. Physician must not abandon duty during epidemics. Recognize pharmacy and nursing as professions. Seek their cooperation whenever required for the patient care. Unethical act physician must not aid, or commit any of the following acts. So, in advertising liability on resumption of another practice or succeeding to another practice, and public declaration of charges. Debates, human rights and euthanasia. Physician may patent instruments, drugs, but unethical if the benefits are obtained from the public. Physician must not sell medicine prescribed by others or surgical appliances, may supply own patients without explanation. No gifts, gratuity and commissions or fees paid for referring patients or specimens is strictly prohibited. Prescribing secret remedies of unknown composition is unethical. All drugs must carry a proprietary formula. Patients shall not aid torture, inflict mental or physical trauma or conceal torture inflicted by any agency. Practicing euthanasia is unethical. Withdrawing life support requires a team decision and not the trained physician alone. Code of the conduct, doctors and the pharma industry. So, value from the 1,000 or 1 lakh in the gift value as the remover has a various punishments. Removal for more than 1 year will be at most gift amount is greater than 1 lakh. So, hospitality and cash tax. So, same graduated punishment scales applies to hospitality, hotel accommodation and cash counter grants also. Research, autonomy and endorsement. Research with pharma funding is allowed only if permission obtained, ethics committee clearance, source or amount disclosed, human warranties are protected. Freedom to public is guaranteed. Never compromise professional autonomy or autonomy of the medical institution when dealing with the pharma industries. May work as consultant, researcher for pharma, must maintain professional integrity and protect patient interests and fully disclose all affiliations. A physician shall not publicly endorse any drug or product. Studies on efficiency must be published through appropriate scientific bodies or journals. Professional misconduct. Acts of commission or omission that constitute professional